going to declare the meeting open to the public. Just to advise everybody, as always, the committee meeting will be recorded and broadcast throughout Parliament buildings, also online. Apologies. Orlia? Yeah. Orlia. There's an apology. Any other apologies?
Miller's running late. That should be
okay. Fair enough. Chair's business. So, just to advise members, myself and Danny, Deputy Chair, and the Clerk met informally the other day with Peter McBride, Tuesday it was, in relation to his work with the Belfast Trust. So there was a discussion in relation to his work over the coming months, and it was agreed we would invite him to give formal evidence to the committee after a recess, once some of his initial work had taken place. Okay. The only other thing to say is we had a really good visit, me and Colin, this morning at Ulster Hospital Encompass. Obviously it's on the agenda today, but I think it's important to put on record our thanks to the staff there. They were very hospitable and we learned a lot from it. Okay, item number 3, draft minutes. Refer members to draft minutes of the meeting held on 19th of June 2025. Everybody content to agree them as drafted?
Agreed.
No matters arising? None. Okay, item 5 on the agenda, members, is SL1 from the Food Standards Agency. Can I refer members to papers at tab 5, including a summary, which is at page 19, and an SL1 at page 24? Can I welcome from the Food Standards Agency Richard Annett from Food Standards Lead, and Sharon Gilmore, who's the Head of Standards and Dietary Health. So you're very welcome. I'm going to hand over to yourselves just for a very brief overview, and then we'll maybe take questions.
Thank you. Thank you, Chair and members, for this opportunity to brief the committee. My name is Richard Annett, and I am the Food Standards Lead for the Food Standards Agency in Northern Ireland. I am accompanied by my colleague Sharon Gilmore, Head of Standards and Dietary Health. The Food Standards Agency is an independent, non-ministerial department, and our main objectives are to safeguard public health and protect the interests of consumers in relation to food. Our fundamental mission is food you can trust. The proposed statutory rule seeks to transpose changes to the EU Breakfast Directive and provides enforcement for new requirements. The changes to the Breakfast Directives relate to the labelling, composition and marketing of honey, jams, marmalades, fruit juice and dehydrated milks, with an aim to increase transparency and inform food choices. This is achieved through introducing new requirements alongside increased flexibility and an opportunity for innovation. The Democratic Scrutiny Committee considered these changes in June last year and did not move to an inquiry. Since then, we have continued to engage with stakeholders, consulted upon our proposed approach to transposition and enforcement. The Committee for Health will have an opportunity to scrutinise the draft rule once it is laid. And once again, thank you for this opportunity today, and we're happy to take any questions you may have.
Thank you. I should declare at the start I was the chair of the Windsor Framework Democratic Scrutiny Committee at the time of the decision not to hold an inquiry. It was very interesting, and at my age in life it was the first time I fully understood the difference between marmalade and jam. So in terms of our role here, I mean, you'll say we will get a chance to scrutinise on down the process. I just can't remember off the top of my head whenever it was in front of the DSC. Impact on businesses here. So obviously it'll have some impact on production and labelling. So the FSA are saying it's got no specific cost requirements for the department. Any cost impact on businesses?
Yes, well, the statute rule itself will be accompanied by a regulatory impact assessment. But to date, what we've done is concentrated on impacts associated with familiarisation costs, and that's coming in at around £1,000 for businesses and £200 for our district councils. We've engaged quite thoroughly since the proposals, and to date there hasn't been any significant concerns or responses relating to major impacts on businesses. Our most recent consultation, we received 6 responses, 4 of which were from the honey industry relating specifically to the honey proposals, and they raised concerns in relation to the origin labelling of honey, and that's something that we're going to try and look into further and make efforts to reach out to those businesses in Northern Ireland that may be blending honeys that might be impacted by the changes and inform the regulatory impact change. We did a stakeholder mapping exercise, and we know that we have around 109 businesses in Northern Ireland that handle these commodities. And within that then there's around 60 of those are honey producers, and the information we have to date would suggest that the vast majority of those businesses handle what's called single source honey, so not blending honey and not impacted by those changes. So because of this new information that a few of the respondents have raised concerns about the honey origin changes, we're going to make efforts to try and identify whether we have blenders of honey in Northern Ireland and get more information.
Could I just maybe follow up as well? The £1,000 that Richard cited there, that is for the 108. That was calculated for the 109 businesses. It wasn't per business.
Yeah, no, I
as such.
understood that.
Yeah, thank you.
And then, I mean, just obviously because we're the health committee, regulation, its impact on the healthiness of jam, marmalade and honey.
Yes, so the requirements or the changes take form by way of new requirements in businesses, but also some increased flexibilities and opportunities for innovation. So some of the key areas are the likes of the honey changes, where consumers would now have the identification of origin at country level in order of descending weight that contributed to the blend of honey. So that's more information for consumers to inform their choice. There's also changes relating to an ability now to make a reduced sugar fruit juice, where beforehand we didn't have that ability, so that's an alternative for a healthier choice on our shelves. The jams and marmalade changes relate to compositional changes, so jams will have more fruit and less sugar in them. And by and large, the aims of the proposals themselves are around informing consumer choice and to make healthier choices.
Linda?
Just in terms that you said you had engagement with the business, just to check, and engagement with the councils, I'm assuming as well, and they haven't raised any concerns?
No. Yeah, these are an extension of current criteria, so they're an amendment to current regulations. So no,
They're already kind of doing the job.
And the same enforcement approach. Yeah.
That's okay. That's
Yeah.
that answers it.
Yeah.
That, Chair, thank you.
So these regulations are not going to be adopted in GB?
At the moment, the common framework across the 4 nations, yes, we are discussing them, but no, they will not be adopted as such. This is an EU directive that we are transposing and has to be in place by December of this year.
What's the issue if it isn't transposed by December of this year? Do we stop producing honey or jam?
Not as such, no, but do you want to say anything further, Richard?
It's just this SR itself is transposing or incorporating the rules into Northern Ireland legislation and providing enforcement for those rules. So we have existing legislation that already adopts existing requirements here, and so this relates to being transposed into Northern Ireland. There are still ongoing discussions and considerations in relation to GB nations adopting similar changes, and it's our understanding that we're under an obligation to transpose these in Northern Ireland by December of this year.
So if I put this into plain language, these are EU rules or EU changes to an EU directive which have been made in the EU with no consultation with us, and we are simply meant to adopt our law accordingly. And I would not be voting for that, because we would simply be adopting EU law. We had no input into that EU law, and I cannot for the life of me understand why politicians in Northern Ireland don't want to make laws for their own people. That's my view. So today's just a briefing, isn't that right? That's my view.
Chair.
Alan, you're
Danny?
happy
Chair.
to say.
Chair.
Danny?
Thank you, Chair. Can I just check, obviously there are benefits, the health benefits you'd covered there, Richard. Is it fair to say that these amendments won't impact the flow of goods from GB to Northern Ireland and vice versa?
Yes, so products produced in Northern Ireland still have access to the UK and the EU markets, and products produced in the rest of the UK will be still available in the Northern Ireland shelves.
There's no impact at all?
No, not that we're aware of.
So, I mean, just in terms of Diane's point, if it isn't transposed into law here, it will mean that producers here can't export these products to the EU because they won't meet EU regulations. So that's certainly an impact.
Yes, and some of the aims of the proposals themselves that are to increase transparency and inform consumers, and some of the opportunities for innovation of industry, like the ability to market a product called reduced sugar fruit juice, won't be available.
Yeah, and I mean there was consultation across here and across the water, and the impact was considered extremely low. It's on the explanatory memorandum. Okay, so we thank you very much. Sorry, go ahead, Alan.
Could I just ask, of those who responded to the consultation, of which there were 4 who expressed opposition, were they individuals or were they producers?
There was a mix between industry representatives and producers.
Would it be worthwhile hearing from them at some point? Can we do that? To listen to their concerns?
I mean, I'm not saying we can or can't do anything, but that was an issue for the Democratic Scrutiny Committee that went through all of this and took a decision not to have an inquiry. I was the chair at the time, so I kind of had to declare that interest, but we decided not to have an inquiry because we thought the impact was extremely low and minimal. And we had all the information that's been provided here, plus additional information. It's a real, I mean, the issue of this is, I mean, I'm open to suggestions, but it's a very, very.
Sure.
Go ahead, Linda.
If members want to meet them, I think that can be done informally. I think we have so much on our plates, and that's not to minimise anything, but this certainly is not a priority. And that's, again, not no disrespect to the issue. In terms of the Health Committee, I'm sorry, it's not.
Yeah. So, from your point of view, thank you very much for attending.
Thank you. Thank you.
So, what do I need to do just because of... Okay, so we might need a vote on this. Our members, my question to you is, are members content with the merits of the policy and that statute rule is made?
No.
So we're just going to take a vote on it. I think it's probably the quickest way to expedite that. So those in favour, raise their hand. Five. Those against? 3. Okay, so 5-3. So the committee is content on the merits of the policy and the statutory rule is made. Moving on, item number 6, oral evidence. That's the first vote of the Health Committee in my time here. Oral evidence on the inquiry on access to palliative care services. Can I refer members to papers at tab 6?
Health issue of
Chair, it might be useful just to record the vote and the numbers.
Just to record who voted what way.
Clerk has that.
I think most will be able to work it out. There'll be no shocker.
We won't tell anybody, Dan.
You'd have been
Spoiler,
disappointed. You'd have
Diane
been
voted yes.
disappointed.
Right, moving on. Oral evidence on the inquiry to access to palliative care. So, can I refer members tab 6? We have a clerk's memo, page 30. And can I welcome Peter Armstrong, who's the chair of Palliative Care Pharmacist Group. Peter, just going to hand over to yourself just to give some brief introductory remarks and then we'll take questions.
Brilliant. Thank you very much. And thank you, Chair, for giving me the opportunity to address the committee and to the committee as a whole for investing your time and resources into this inquiry. My name is Peter Armstrong and I am the Regional Lead Pharmacist for Palliative and End of Life Care. Today I am representing the Northern Ireland Palliative Care Pharmacy Group, of which I am the Chair. This group consists of the specialist palliative care pharmacists, the majority of whom are non-medical prescribers embedded into the multi-professional palliative care teams in the trusts, hospices and some community areas of Northern Ireland. In some sense, we would be similar to the regional medical and nursing groups from whom you have already heard and with whom we work very closely. We share good practice and take a leading role in the development of regional guidance and quality improvement to benefit palliative care patients. We also have close working relationships with Trust Pharmacy Leads, SBPG and Community Pharmacy Northern Ireland. In Northern Ireland, our current palliative care strategy, Living Matters, Dying Matters from 2010, recognises the role both specialist palliative care pharmacists and community pharmacies have in the care of palliative patients. In addition to the other representatives who have spoken to the committee to date, we would welcome an updated strategy which further recognise the key role pharmacists across all healthcare settings can play in supporting patients and carers. The role of the hospital-based palliative care pharmacist in Northern Ireland has been evaluated and demonstrated a direct benefit to patients' quality of care with associated cost savings and the potential to reduce the length of stay in hospitals. Currently, while there was some specialist palliative care pharmacy input into all trusts and hospices in Northern Ireland, the whole time equivalents vary greatly. For hospices, the source of funding also varies, being a mix of departmental funding and for some hospice posts, their own charitable funding, bringing into focus the need for people to run marathons to find the funding for essential palliative services. As a profession, we are underrepresented compared to the Northern Ireland Palliative Care and Partnership Workforce Planning Report from 2017 to 2024. This underrepresentation has a direct impact on patient care, especially at the primary-secondary care interface. In a recent study of palliative care discharges from a Northern Ireland trust, palliative care patients went home with an average of 16 medicines, the range being 3 to 26. When we used a validated tool to look at the complexity of this medication, the total score was well above that of any other specialities in the published literature. You can imagine the impact managing all these medicines has on patients and carers on top of coping with their diagnosis and the other aspects of their illness. Palliative care pharmacists in Northern Ireland have demonstrated a positive effect on managing patients' medicines on discharge and in community, yet we do not have the adequate resources to support these patients as they transition between different care settings. Access to palliative care medicines in community is a common theme that you have heard during previous evidence submissions. Many of you attended the Marie Curie Daffodil Standards for Community Pharmacy event held here in March. I know that community pharmacies are the most accessible source of healthcare and are ideally placed to support patients with a terminal illness. We know the huge contribution community pharmacists make towards good end-of-life care in their local communities, frequently going the extra mile to ensure the very best care for their patients. Whilst the Daffodil Standards will have a positive impact on care, they are an unfunded initiative for community pharmacies and do not address some of the fundamental issues. We have fragmented supply arrangements in different areas of Northern Ireland and an overall system that is hard for healthcare professionals, never mind patients and carers, to navigate at the most challenging of times, which are evenings, overnight and weekends. We have 61 community pharmacies out of approximately 509 who are funded to stock palliative care medicines, but they are only available during that pharmacy's individual opening hours, which especially in rural areas may not include evenings and weekends. Only Belfast has the provision of a community pharmacy service that can be accessed overnight to supply palliative medicines. Other areas have a mix of Sunday and bank holiday pharmacy rotas, but the pharmacy may only be open for an hour or two in different towns, and they may not routinely keep palliative medicines. Even if a pharmacy is open, if they do not physically stock a medicine, then there will be a time delay while it is obtained from a wholesaler. Some might only be available next day delivery from England, and wholesalers are not easily accessible outside core working hours. Sadly, there are often shortages of even common medicines, so you can see the challenges we all have navigating this system. It is easy to think we do palliative care well in Northern Ireland, and the question as to how to rate our local services did cause some discussion when the pharmacy group developed this submission. Sadly, all the pharmacists were able to tell stories of patients and carers struggling with our system. The carer of a patient in Fermanagh had to travel to Omagh to get a prescription from the out-of-hours centre over Easter, and then on up to Derry to find the only palliative care community pharmacy open that would definitely stock the injectable medicines needed for urgent symptom management. A patient's family was able to get a prescription from the out-of-hours GP in Coleraine, but had to travel to Antrim to get the medicines, with the family going there and waiting. When they returned home, they were told by the district nurse that they would be unable to administer the medicines as they did not have the required paper administration chart signed by a prescriber. Again, someone returned to the out-of-hours centre to collect this to enable the administration. Finally, a community pharmacy opened for a 1-hour Sunday slot in their town for emergency medicines was faced with a complex and urgent palliative care prescription for medicines which they did not stock. In this case, by chance, the pharmacy was part of a small chain, and the pharmacist later drove to a different pharmacy in the chain she knew stocked the medicines, opened up that pharmacy, dispensed it, and delivered it to the family in her own time. However, it is important to remember that pharmacy is the last point in the chain, and very frequently, when we have looked at the supply crises that I've mentioned, there have been opportunities missed during core hours to provide these medicines. So there needs to be a shift for all healthcare professionals around firstly identifying the deteriorating patient, and then the importance of anticipatory prescribing to ensure patients have these medicines in the home when they need. This is the best way to prevent needing to access medicines at evenings or weekends. It is hard not to look at other areas and see examples of different practice. In England, all community pharmacies have the funded option to stock an agreed list of palliative care medicines. I have a friend whose wife is receiving palliative care, and they live in the small, mostly rural county of Dorset in the southwest of England. Their closest town is Yeovil, with a population of 40,000 people. However, they have access to a 24/7 nurse-led palliative care helpline. These nurses are independent prescribers who can issue prescriptions. They have electronic prescribing, so can then send that prescription to a community pharmacy of the patient's choice. And Yeovil has a selection of late opening pharmacies which are funded to stock palliative care medicines. Contrast this with our patient going from Enniskillen to Omagh to Derry and back again. Whilst the introduction of Encompass has seen many benefits in hospitals, hospices and general practice have only limited access, and community pharmacies have no access, which reduces their capability to ensure safe and accurate prescribing. Access to shared records, including for community pharmacy, is a recommendation from multiple UK-wide reports into accessing palliative medication. In patients' homes, nurses are still requiring pieces of paper in the home with the patient in order to administer medicines, and as I mentioned previously, if these are not there, urgent trips to the GP or out of our centres to get the medicines written on a paper chart as required. In Northern Ireland, there is currently no electronic option available that might enable this task to be done remotely. You will have heard previously about the role that just-in-case boxes have played in improving access to medicines at the end of life in the Western area. However, their use is not fully embedded across Northern Ireland, and even then, while they have proven to be an extremely useful tool to enable anticipatory prescribing, they are not a panacea for all medication supply issues. More broadly, you will have heard previously about the lack of a clinical lead for palliative care in Northern Ireland, and how this is needed to provide direction and drive improvement for palliative care services across the region. I too was at a recent UK and Ireland palliative medicine conference where the clinical leads for England, Scotland, Wales and the Republic of Ireland opened the conference, and it was notable for all attendees that such a post from here, with Belfast being the host city for the conference, was sadly lacking. In summary, we do have some pockets of really good care here in Northern Ireland, and from a pharmacy perspective, in common with other professions, we have an incredibly willing, knowledgeable and dedicated pharmacy workforce across our hospitals, hospices, community pharmacies and GP practice pharmacists. Pharmacists and investment in pharmacy services can definitely provide solutions to many of the issues I have raised, and we feature heavily in the Hospice UK report published just this week around improving palliative care in rural communities. However, the best way to prevent issues around patients accessing palliative medicines is to ensure the medicines are in a patient's home in advance of their anticipated need. This provides reassurance for carers and greatly reduces the burden on them, freeing up their time to spend with loved ones. It also reduces pressure on out-of-hours services and can prevent patients resorting to attending emergency departments as they seek symptom management and access to medicines. Compound the difficulties we see in ED, and more importantly, this is the wrong environment for palliative patients who want to stay at home. We greatly welcome the work of the committee in dedicating your time to palliative care, and I thank you for giving me the opportunity to speak to you today, and I'm very happy to answer any questions that I can.
Okay, thank you. As always, that was very informative. Some of the stuff we had heard before, but some of it was new. So only 61 out of 509 pharmacies here in the north have stocked drugs that would be considered palliative care.
Yes, so they're the ones that are funded to stock them as part of the community pharmacy palliative care network. As you probably know, community pharmacies will only get paid for a medicine if they get the green HS21 prescription. So in England, they have the option to fund them through their NHS England contract to keep those medicines. And I suppose, you know, pharmacies maybe who are seeing a lot of palliative care will probably naturally keep them, but with the current situation, community pharmacies, you know, they can't be keeping lots of medicines that might be going out of date because they won't get funded for them.
Do we have any sense of the geographical spread of those 61?
I mean, they are spread throughout Northern Ireland, and we do have a good spread, but I suppose patients still have to travel. Some of those pharmacies may not be open weekends and evenings, and I suppose just then sometimes it's actually just getting that information out there. I mean, we do have some information on NI Direct about how to access them, but if you're a carer in your own home and suddenly you have a prescription, there can be challenges finding out where your local one is.
I mean, you give an example of a family up around my neck of the woods on a Sunday, and we've heard typical examples of that. I mean, that's a really unsatisfactory situation for a family with someone at the end of their life having to drive around between hospitals, pharmacies, shops, whatever. I mean, how can we improve that?
And as I said, I think probably the main thing is just to have a conversation around, and this is all healthcare professionals, GPs, community nurses and pharmacists, about recognising a dying patient whenever that patient is entering the last couple of weeks of life, and almost having a conversation and saying, well, is this a time when we need to have medicines in the patient's own home? And that would be a big one. You've probably heard about the non-medical prescribing and the foil hospice pilot, which has been really, really successful in reducing the pressure on GPs services. Like from this year, pharmacists are coming out as undergraduates with a prescribing qualification. That foil hospice pilot was really, really successful, and it's just about then, all these sort of reports that have come out, UK-wide reports have said, increase the number of non-medical prescribers. And I think in the foil hospice report, the nurses were in the home seeing a patient who's deteriorating. They issue a prescription there and then, and then you get the medicines really quickly. So those are probably the biggest things. But also then, if you have a patient in Balleek and a family member goes to Balleek, and a pharmacy, knowing that they stock, or they are funded to stock, even a small amount of palliative care medicines would be really beneficial, because you will have that reassurance that anywhere you go in Northern Ireland, I know that they will have the maybe 4, 5, 6 core medicines for palliative and end of life care.
Thank you, Colin.
Thank you, Chair. Thank you for the presentation. It gives us exactly the scenario that's there, and I was thinking of and reflecting of using the word sort of shocked, but I'm actually more saddened, and the sadness comes, Chair. Saturday is my dad's 30th anniversary, and we nursed him to death at home, and I had to do the same thing back then. I had to get into a car and drive around to go from pharmacy to pharmacy to try and get the right medication that was needed. And it's sad to think that 30 years later we're still hearing that families are going through the same thing. So as much a comment, I suppose the chair had asked about what would it be that could do. At its core, is it just money, or are there systems that could be changed? I mean, if you said there about people having those services or those access to those drugs at home, is that something that's not legally permitted at the minute, or is that something that just isn't organised? I mean, what could we do to achieve the change that you're thinking about?
I suppose there's a mix of both. In terms of there's certain sort of legal aspects around, say, care homes stocking palliative care medicines. They would have to have individual patient medicines, so that is a legal aspect. Again, there might be some for out of our centres, that they maybe can't stock these medicines, although some in maybe England, it's about applying for licences and things like that, and that is a hurdle for them. But otherwise, it is just about having this shift, and the just in case box pilot in Western area, it's so fully integrated now into hospital palliative care teams, community pharmacies, GPs, community nurses. The community nurses are seeing a patient in community, and it's like you flick a switch. Something happens, we recognise this patient's deteriorating, we get the medicines, we get this paper chart that I mentioned, and that even actually facilitates a conversation with the family as well and provides reassurance. So even if you don't use those medicines, there are benefits there for the patient and carer, knowing that things are in place should they need them.
And just very quickly then, we have a presentation next on Encompass. Is there ways that Encompass could help if it was developed? Because it was made really clear to us this morning that the introduction of Encompass isn't the full stop, it's only the beginning of the journey. Are there ways that Encompass could be utilised, that if somebody is on the Encompass system and does have a change in their circumstances, that could be uploaded onto Encompass and it would trigger the right drugs being delivered into the right area. Are there opportunities there, or is it just too complex?
No, I think there are, and with Encompass, and certainly, you know, with the plans to link in the hospices would be a really useful step. And you wouldn't, you know, if there was a way that then, you know, I brought one of those today, this is the paper charts that we mentioned, and you wouldn't think that it was too hard for, whether it's a hospital practitioner, a GP, a non-medical prescriber, someone to prescribe something on Encompass, and then a district nurse in the home be able to, you know, to say, listen, I have given 10 milligrams of this medicine at this time, which is essentially what this form does. But you have patients and carers running across country to try and get a paper form, that sadly needs that. So they're definitely Encompass it. You know, there are solutions there.
That's good. Thank you, Chair.
Linda?
So, I mean, we know that there are blockages to this that aren't financial, and I think you've hit the nail on the head, Peter. I think the communication and the work with the hospices is essential in this, because in my view, nobody understands better than they, and obviously their community provision as well, and Marie Curie organisations that specifically work with palliative patients. Nobody understands better than they how this works, and I just don't think there's enough. The department isn't listening to them in terms of changing processes, because part of the reason why you can't have the medications in the house, and you'll know this better than me, Peter, so I'm just wondering, have you any solutions to this, or to help us to find solutions, or is it a case of we just need people to sit in a room and hammer it out, because some of it will be around governance. But for example, a patient has to be administered, I think it's 3 times breakthrough before they can get the medication that will actually relieve them of their pain. But you can't know on a Friday that they're going to be administered. Now, you'll have a fair idea, and you'll probably know it is going to happen, but how do we get past that? It has to happen before you get because Colin's right, I mean, that is exactly how it's still happening. I've been there myself. You don't think about it when you're in the middle of it. When you look back at it and think, my God almighty, and I always say this, we were very lucky as a big family. We had lots and lots of support around us, but there are lots of people out there that don't have that. I spoke to a woman at the lived experience. It was just her and one other family member. So when she left her daddy, that was it. You know, if he died, he was on his own. So I think this is a really, really important element of this, and I'm just wondering, do you have any answers to that, or is it get people into a room, work out how the governance can be better done, or how the processes can be better put in place?
I think obviously we have a lot of messaging around reducing prescribing, and especially the sort of medicines we're talking about, opioids and things like that. And with anticipated prescribing, we're sort of giving a slightly different or more the opposite message. So I think there does need to be sort of messaging around, even at a population level, around palliative and end-of-life care and what it is, and sort of saying, you know, it's okay to have these medicines in the house. It's okay to prescribe them early. You know, from these pilots of the just-in-case boxes, you know, the medicines are used, and as I said, there is even benefit if they're not used. But I think it almost needs that wider message that this is acceptable. It's acceptable to prescribe these opioids in advance of patients, if patients needing them, because, you know, the district nurses are going in and checking them every time that they're in. So I think that messaging, not just for healthcare professionals, but actually for the whole population around palliative and end-of-life care, is really important.
So it's about getting the balance that, yes, absolutely, we don't want overuse of medication. I am 100% an advocate for that, but I think when people are end of life, to not be getting access to medication is going to relieve them of pain, and not to put their families through that running about, but also watching the person they love in agony and not knowing what to do in some cases. So running around the country is one part of it. Another part of it is a family may just think, we just have to wait until the next nurse comes and see what happens here. So I think there is definitely a piece of work needs to be done there around, and the hospices and those who provide palliative and end-of-life care are vital in this conversation, and the department just shouldn't be putting in place any processes without engaging with them fully, really listening to their perspective.
Okay, Diane?
Just very quickly, and thank you for the presentation. I think what I have taken from a lot of the presentations is the lack of information for patients. So you're talking about patients, for example, having to drive around the country looking for a pharmacy that would dispense the drugs that they need. And you can imagine, you know, the anxiety and so on, the person that's doing it, they've a loved one in pain. This is a really, really deep, troublesome scenario that you're describing, that people in a panic are looking for medicine that can be pain relieving. And I think there's a couple of things that the committee probably, and I'm probably talking to myself actually more than anything, but it's around, one, Colin mentioned the systems, two, it's about information. The third one is how on earth you bring all that together, because I am not sure the health service does that very well at all. And it always seems to me that it's different in different parts of Northern Ireland. And I suppose the bit maybe specifically to the pharmacy, I mean, in my area, lots of pharmacies now don't open on a Sunday, not even for the 1 hour dispensing period. And on top of that, you have the added complication, well, is the pharmacy that's open going to have the drugs and be able to dispense the drugs that I need? And how do people know which pharmacy is going to be able to do that? Or is this potluck of running around and saying, and it's all about communication, and how people do that. This is the most stressful time in a family's life. And it's very difficult to see how these systems are not working. Now, I know that their main nurse may well have that information, but sometimes a lot of families, like my own at times, have dreaded the weekend coming because they've nobody to contact. So how can we improve that? What are the recommendations that we can make that actually help to improve that scenario?
I think you're right. It's challenging if you're a carer there, and we do rely on getting knowledge of these pharmacies out to GPs, out of our centres, district nurses. But it's really challenging. We did get I put some information on NI Direct, but again, you're relying on people to Google that, so it's not a perfect system, and. To mention, and you may have heard, in some places of England and Wales now, they're utilising paramedics as well to deliver, to administer medicines. Some places in that Hospice UK report are sort of advocating using, paid couriers, or the likes of the people who deliver, the motorbikes who deliver bloods and things like that, to actually do that work in terms of getting those medicines. So there are different options, but at the minute it is really, really challenging because there's not the sort of information out there, and there's not the information, or there's not really the conversation around palliative and end of life care, I suppose, at a population level yet. And it's only really actually when you're maybe in that situation that then you sort of start to think about it. So I think there can be sort of a greater messaging around palliative and end of life care as a whole.
I do think that that's something maybe we need to think about when we're finalising the report. I just think that there must be ways that we can inform people more and more, because it is so difficult and it's so emotive and it's so challenging for families. But thank you for your presentation. I think there's lots of things in that will help us when we come to sit down and formulate the recommendations. Thank you.
Yeah, but just building there on what Diane is saying about information, I'm just wondering if when a prescriber is writing out the prescription and handing it to the family, the family just take the prescription and don't realise that, hey, I can only get this at something like 10% of the pharmacies in Northern Ireland. I'm just wondering, does the prescriber point that out to the family and say, look, you need to be going down to your high street because you may not get it there, you may have to travel and stuff. And it does put stress on people. I can imagine somebody getting into their car and their mission is to get drugs to take their loved one out of pain, and end up crashing into a wall or something, just because of the stress on them to try and do something quickly. But the thing that jumps out at me is the possibility of a dedicated website that would contain the names and can be readily updated at no great cost by someone. And it would contain all the geographical, each county, what pharmacies were funded to hold these drugs, what their opening hours were, what their contact telephone number is. And that might help to take a lot of stress. So a family could, rather than jumping into their car and driving like a rally drive around the countryside, they could pick the phone up and ring half a dozen numbers and say, look, are you open? Do you have this? And it would take a lot of stress out of it. So I'm just wondering, has a website been considered, or maybe it does already exist?
I think definitely there is so much room for improvement in that area, not just from what you've spoken about, but almost like a website, Northern Ireland Palliative Care Hub, that linked in, the GPs, the out-of-hours centres, the district nurses, the patients, that you could all sort of go into to find that information. And because it's really challenging just for the community pharmacists themselves, because they want to supply the medicines, but they may not have them. And the thing that you might find is, if they only have one of the medicines and they dispense that one medicine, they can't give that prescription back to go to go the other two, which you may have heard. And then because of the lack of patient records, they might not know the urgency of that. So the whole sort of system there, can do with improvement. And you're right. And a central website or a hub would be a really, really great step.
I think
for
as
that.
well, highlighting the fact that it might be unfair to the other pharmacists who are making the effort to have these drugs and to provide them, that you say that there's one place in Belfast that's a 24/7. I think that's got to be like in flashing lights on a website that, if all else fails, here's where you go. And it might be easier for people to jump in their car, even to drive 50 or 60 miles to go to Belfast, with the surety on a 24/7 basis of being able to get the drug, rather than chasing around the countryside with a half hope that they might get it, or might get half their prescription rather than the whole prescription. But I think a website is something that it's an easy solution, it's something that should be considered.
Mm-hmm. I think even some of those reports are saying about funded delivery services and things to actually even take the pressure off carers about having to get in the car at all, would be really, really helpful.
Yeah.
Thank you. Danny?
Thank you, Chair. I absolutely agree, and we have heard the same issues again and again, but very, very closely defined with what you were saying about the pharmacist's experience, and what Colin described from 30 years ago that's still happening today is horrendous. I'm very familiar with your syringe driver prescription chart there, a background in nursing, and the idea that we're still filling in pieces of paper in order to get drugs is absolutely crazy. Hopefully Encompass will be rolled out into the community, and that would make that a lot easier. And certainly the just-in-case boxes is a fantastic idea to improve that access. A couple of questions. The Northern Trust, if I read it correctly now, it says that the Northern Trust is the hospital pharmacist is on call for the Northern Trust area.
With the Northern Trust, they have the community pharmacy palliative care networks. So in terms of the hospital, they have an on-call pharmacist there, but they wouldn't be sort of, I suppose, funded or set up to provide emergency cover or emergency medicines, and they're based in Antrim, so it doesn't really help your patient in Ballycastle or something like that. So I think they, out of their own, as the pharmacists do, and you've probably heard, out of goodwill, they provide that service, but it's not a sustainable service, and it's not a funded service,
No, it does say it's an unfunded service, and the responsibility falls then to the on-call pharmacist for that whole area, which obviously, given what you've said about long distances and things like that, does seem to be.
It's about long distances, and it's about capacity, and it's about, I've done it myself in central Manchester, and you're in ED looking for someone waving about a green prescription in the middle of the night, and it's terrifying. As a pharmacist, it's probably terrifying for the patient or for the carer being in ED, and it's not a sort of good or sustainable system, and we certainly do need to look at more local arrangements. So.
Why is there such disparity across the trusts? What is the best practice, and what do we need to do to bring up the rest of the trust to the best practice?
I suppose it's challenging, because of the geography of Northern Ireland, and when I talked about that, the system in Belfast with the sort of out of hours pharmacists. That's a system that works well in Belfast because of the population density, and it's something that actually other big cities, Edinburgh and Lothian area, have. But actually, then whenever you go out to more rural areas, that system isn't sustainable. So you do need a really heavy emphasis on actually, like I talked about, the anticipatory prescribing, embedding the community pharmacy into actually the whole healthcare team, so that they're aware, so that the family and the district nurse are all aware of that. And it may be, as you mentioned, Belfast, getting a courier to go to Belfast may be, in terms of resources, actually the most acceptable option if something is needed in emergency.
I absolutely do get that. It sounds horrendous to send a courier to go and pick up stuff on a piece of paper, but as Linda was saying, that these are precious hours for families. They should be with their loved one and not having to be shuttling about across Northern Ireland to get drugs. But that's great. Thank you very much for that.
All. Yeah, thanks, Chair. Peter, note in your submission you'd said how the postgraduate pharmacists, foundation year and undergraduates, there was no regular and varied training opportunities, and there were no opportunities for training for pharmacists. How do we rectify that? Given you would have thought pharmacy services are from the cradle to the grave, you would have thought palliative care training in some aspect would have been afforded to them. That, I suppose, was a bit of a sort of eye-opener for me. And is that a UK-wide issue, or is it exclusively to Northern Ireland pharmacists?
It's probably a UK-wide issue. I mean, you do, in the undergraduate level, we do a tiny bit, but it really needs embedded at all stages. And there, at the minute, there is a palliative care and partnership group looking at education and training, and actually hoping to bring different tiers of education. So even if you at the lower tiers, you maybe are only slightly involved in palliative care and palliative care patients, then actually you will get mandatory training, a bit like we get all our mandatory fire training in trusts or things like that. Could you get mandatory training in palliative end of life care? So you just actually have the basics embedded. And there's trouble for, it's hard for community pharmacists to get away, because they're obviously the only pharmacists there. They need to be in their community pharmacy for it to legally operate. So, how do those guys get away to do their training? There's a lot of goodwill there, and they put in a lot of effort in the evenings for their training. So those are some of the obstacles as well.
Okay. Peter, thank you very much.
Thank you.
It's been very informative. Really appreciate you coming before us.
Thank you.
Okay, members, moving on, item number 7 on the agenda, oral briefing from the Department on Encompass. So can I refer everybody to tab 7 in our pack? We have a written briefing at page 49. And even though I said it earlier, just to repeat, can I thank the staff at the Ulster Hospital this morning for hosting. Myself and Colin were there, and committee staff. And thank the South Eastern Trust and Encompass regional programme for providing very informative presentation on Encompass. And to that, can I welcome Dr. Paul Rice, Chief Digital Information Officer within the Department of Health, and Dr. Dermot Hughes, Senior Responsible Owner within Encompass. So, this is twice in the one day for some of us. So I was just thanking the staff and yourselves earlier on for the very informative visit to the Ulster Hospital. So you're very welcome. I'm going to allow you time to give some brief opening remarks, and then we'll just go straight to questions.
I think that's on. Can you hear me okay?
Yes.
Thanks very much for inviting us here. I suppose I'll give you a quick 5-minute update so you know where we are. We successfully went go live in the south and west on the 8th of May, and in doing so, in a total we've trained 82,000 staff, and we have a 15,000 what we call super user. These are people who volunteered to train to a higher level and support their colleagues. The go live in the south and west was very stable, and we had no digital clinical incidents, and we had only one issue where we had to reconvene the regional groups to look at a pathway, and what that means is that by the 4th implementation the patient pathways are very stable, and it will mean back to activity will be quicker, and back to getting data out will be quicker. The south and west are both going through a stabilisation process, and there are no issues with that, and we're comfortable with that. The Northern Trust is almost back to full activity, and the Belfast Trust and the South Eastern Trust are back to full activity. Because of the sequential nature of the implementation, there's a rush to do more, and you can imagine if you're in the South Eastern Trust, you've been 18 months waiting to transform the service. So we're meeting tomorrow with the Directors of Performance and Planning to step out the first steps of transformation, and how that aligns with, say, the themes from the big conversation, and how that aligns with the views of the Permanent Secretary. We're going to have a regroup at the end of July to see how we take this forward. The programme has several pieces of work still ongoing, and I'll just beyond the trust work. What we're doing currently is we're building out mental health frameworks outcomes, and that's going to be built out on the MyCare app, and that will be completed by the 30th of June. And it's a way of having standardised, clinically templates sent out to multiple patients so they can give feedback on their mental health outcomes after outputs after treatment. The other issues that we're managing is that we're bringing in the independent medical examiner's role. So that means that people can review information independently on death certification, and that will be shared with the coronial officer if required, and the GRO. So that's a high-level governance of the whole system in Northern Ireland, and that will be on by September. In November, we're going live with healthcare in prison. The prison population varies, but they tend to be very vulnerable, high levels of learning disabilities, addiction, mental health issues, and it's an opportunity to make sure all patients get the same quality of care irrespective of where they happen to be at that time, and that we're working with the healthcare in prison over 3 sites to do that, and the live trusts will help us go live during that. And I'm sure we're going live with NISTAR, which is an organ retrieval and repatriation process for specialist transport of patients. And as well as that, we have to discuss transformation. And the programme, while being implemented, has a life of another 11 years, and it's resourced for those 11 years. So the aim is to have an ongoing programme of transformation that will shape and change cares to increase productivity, increase patient involvement, and increase the experience or improve the experience of patients. That really isn't an Encompass thing. That has to be a whole system thing that we will help to enable. But so we've had quite a successful go live, but we've had a quick pause, and then we're moving on to do the next pieces of work. So that might be a lot all at once, if you want to ask any questions.
Okay, thank you. So, I mean, as I say, I had the privilege of being at the Ulster Hospital, so I was able to chat to staff who use it, who are the important people, I suppose, in this, along with the patients. So, I mean, I was heartened from the visit this morning where, I mean, we did talk about some teething problems and some issues, but by and large, every one of them were extremely complimentary about the impact of Encompass on their work and on patient safety, which I think is very, very good. So I'm going to ask some similar questions, apologies, that I might have talked about this morning, because it is a really good system and very worthwhile, but it hasn't been rolled out fully to all healthcare settings. So I mean, when we do engagement with GPs, you know, they would say they want to have full access to Encompass. We've just heard there, as part of our inquiry into palliative care, community pharmacists, and their desire to have additional access to it, as well as hospice settings, so, and social workers as well. So moving beyond secondary care settings, you know, what kind of level of access will other healthcare providers have to Encompass, and when will they get greater access to it?
GPs provide most of the care in Northern Ireland. We have to recognise that. GPs have full access to a read-only aspect. It's called Epic Care Link. They have that now. It's an improvement. In the past, the Northern Ireland Electronic Care Record would have sent out information retrospectively. They can see live time what's happening to their patients. They can see drug changes as it's happening. They can also place orders for radiology or bloods, and they can receive messages. So while they can't write on the system, they can do all those tasks. In terms of other aspects of healthcare, is much wider beyond the DHCNI, or the Department of Health, and we're doing some work which is a result of the neurology inquiry, where there was a requirement to have access for the independent sector onto any electronic care record on the basis of patient safety tool. So that work has started, and there will be information governance issues, there will be contractual issues, but the major provider of independent sector care is care homes, it's residential homes, and that's a real important piece for the system at present, because I don't know if you noticed on the board today when they were looking at the data, every ward we went down, the percentage occupancy was 110, 115, 112, and at any one time 20% of the patients are medically fit for discharge but have nowhere to go. So we can try and improve that system by having, as we do currently in the system, an expected date of discharge from day of admission, so that the people in the independent sector will know up front. That still doesn't address the capacity issues, but it certainly will link into the system. The other issues, a lot of independent sector work is commissioned by the Department of Health and waiting lists, and we really think that should be on the same platform, because it's the same quality of care, because people don't necessarily choose to go down that route, or that's a route that the health service chooses for them. So that will take a bit of work. We have adult social care, and I think you heard this morning, the adult social care is working really well on the platform. We still don't have children's social care. That's because they desired what they call family functionality. An electronic care record is your record, one person, and to bring in the family dimension, we had to do some additional build, or so that the vendor did. So that will be ready by Q3 2026, and that will be a worldwide new functionality, which will have benefits for psychological therapies and mental health as well, because often the family dynamics are important in that. But we also need to get a financial functionality along that, which is slightly more tricky, because a lot of children's social work is tied up with very time urgent payments and consequences for foster families. So we're still working on that piece. Other aspects of care, I think the thing we haven't mentioned, everybody in the room can have access to their own medical records. Everybody can be healthcare is really patriarchal at times in Northern Ireland, and I think patients need to be partners in care. And we were talking about this, that we didn't go heavy with the sale on this app because maybe 2/3 of the population weren't on it, but we have to go heavy now, and we've got limited functionality, so we're meeting the DOPS tomorrow to see how we can expand that functionality and make more facilities available. So, not simply just booking their own appointments, but being able to upload their own data, their own results. It's not a portal, it's part of your record. So that if we want to do virtual wards, if we want to do virtual outpatients instead of bringing patients up and down, we can do it differently. In Northern Ireland, in some services, there's 2 review patients for 1 new, and the big problem in Northern Ireland is there's not enough space for new. So that'll be part of our discussion tomorrow, is about how do we change that dial and make more availability. The other issue with the in Northern Ireland is that access to outpatients, DNA rates could be up as 8% maybe. That's a huge wastage. We can obviously give messaging, but we have analytics that can tell you who's most likely to DNA, and we can send targeted responses, but that's probably not enough. We can also release a thing called Fast Pass, so that if somebody signed up to turn up at short notice, we can backfill the empty spaces. So it's a problem that you have to address from both ends, and we have an aggressive plan which we're going to share with the Directors of Performance and Plan tomorrow, and we would like to circulate that. But it won't work if we don't have enough people on the app. And we asked earlier on today, and we're going to do some work about evangelising this, to say, look, it's your health, it's your record, it's your information, and it really does empower people. And I give an example, a personal example of my son who's learning difficulties, could use the app, could go to a psychiatric appointment and put his own medication on, and it just feels he's owning his own issues, which is really important for the future. And I think this will become the future of the front face of the health service. And I know we all say it's successful because we put it in, but that's only the start. It'll only be successful when we transform what we're doing. And I think that's the challenge that we have to be held to.
There was a very perceptive comment made, I think, by one of the colleagues who we saw this morning, who said we're at the beginning, at the end of the beginning. So that's the nature of the situation. The 5 Trust deployment gives us a platform to continue to extend and develop within that context, within that venue of care. But as Dermot's also outlined, there's a whole set and series of other venues of care, which are the ones that you're inquiring about, where progressively over the life of the programme, the question of, as a minimum, the connection between the information held in those venues of care and the EPIC tooling will be a challenge, a question that has to be posed time and time again. And over the life cycle, the appropriateness of some of that actually being fundamentally incorporated into the scope of the EPIC product as we move forward. That each of those junctures will require questions about the requirements, questions about the fitness of products to meet those requirements, the cost profile, the benefits profile, etc., etc. So I think that comment this morning was incredibly perceptive.
Yeah. And Dr. Hughes, my next question was going to be on my care. So you've spoke about it there in your previous answer. So I'm the chair of the health committee. I didn't know it existed. To be truthful, the last time I would have been on that website was probably COVID, in terms of the vaccination passport. So I was on it, and between meeting you this morning and the committee, and I didn't even realise, like, I had a couple of hospital appointments within the last couple of weeks, so I can give my fridge a break moving forward, so I don't need to put the letters to the fridge. They're actually contained within the app, which is good. And so there's medication that I'm on. I shouldn't divulge any personal information in the committee meeting, but there's medication that I'm on that's not in the app, so I can myself then upload that so that will be fuller. So going beyond that, then how, because in the rest of the committee's absence, me and Colin and the clerk have agreed that we're going to have an event in the Long Gallery, because we think it's important in September to publicise this as a tool that the public can use, and as well as ourselves signing up for it. So can you just expand upon what you previously said about how beneficial this is to the individual, but also the health system as a whole?
Yeah, I think if we start with the health system as a whole, we brought this platform and we've implemented it here, but we're by no means the first people to do it. We are unique in that we're the only people who've done community care, mental health, social care, and acute care. But we have partners who helped us get to this place. So we have people who are further ahead on the journey. So we have good partners in Holland who have sort of lots of work done using the app for admission avoidance, healthcare at home, early discharge, and changing how they deliver healthcare. And we don't have to start from ground zero. We can take that work and take their advice and sort of turbocharge what we do as we go forward. Because to be honest, I think if we went to anybody in Northern Ireland and say, like, what are the top 10 things you need sorted in the health service, you'd probably get the same answer from everybody. And they're not challenges that haven't been seen elsewhere. The app has huge potential for people to upload their oxygen saturation. It happens automatically. You just get wearable technology, their respiratory rates, their blood pressure. And the way it's been used elsewhere is that allows earlier discharge for those that need light touch follow-up. And if somebody's not acutely ill, but in essence they often come in, they can have this as an admission avoidance. So it's about decompressing the acute sector. The real concern in the health services is not the 20% that are medically well. It's the people who are unknown because they're on a waiting list, or unknown because they're stuck on ED trying to get in. And our big focus needs to be, how do we make the system better for patients but more efficient? And we've done this in the past. I used to be the medical director of the Cancer Network. I used to bring everybody up for a 6-monthly review. whether they needed it or not. And a lot of people got frightened and concerned about it, and then you'd say, oh, you're fine, go away. So we changed that, and we focused the review on those who needed it most, and the others got maybe virtual reviews or light touch reviews, and say, go and live your life, that's part of your life, not taking over your life. I'm being a beneficiary of that myself, and I think we can roll that out with much more supported technology. I think Northern Ireland is quite a technology enabled society, and I don't think we have any option. I literally don't think there's any option. Do we do the same again and expect something different? And I think the interconnected nature of the implementation is that your social worker will know, your community nurse will know, your GP will know, the hospital will know and can see it, oversee it from distance. And if you have mental health issues, they can all be in the one platform. So the staff have been going round, been asked around Europe to present on this, and you heard the South Eastern Trust staff today, and they're a credit to Health Service. We have something unique that other people are wanting to do. So when we went live in our last year trust, we had the province of Quebec shadowing us, we had New South Wales shadowing us, with the Republic of Ireland shadowing us, and several trusts from the UK. So I think it would be a complete shame if we got to this stage and not take it further.
Okay, thank you. Linda?
You've covered actually quite a lot of what I wanted to ask, Chair. So, I mean, for me, one of the most important things, and you said it, I mean, GPs have access in terms of read-only, they can't write into it. I am concerned about that because I think that that's a big gap. And I know others have talked about the hospice and community pharmacy and others, and I think that is important, and if we can get there, I'd love to see it. But the first step should be our GPs, and I don't think that responsibility should be put on them. Yeah. And I've been asking the department this since long before Encompass was anywhere near any of our trusts, and I don't really think I've got a satisfactory answer, to be honest with you. It's always been a wee bit pushed back. Yes, hopefully GPs will be able to do that someday. That sounds to me like the GPs will have to do that if they want to do that. I don't think that's fair. The department have made a decision to go with Encompass with a big investment, and I think that's the right thing to do. I absolutely am in favour of Encompass. But if we want to get the best out of it, the people who deliver most of the healthcare to all of our citizens, to every one of us here, are our GPs. To get the best out of it, should we not be working to get GPs access, however that's done, whatever kind of software needs to be put in place? Is there not a way to do it?
Yeah. Totally agree. 90% of the healthcare is delivered by GPs. I think the business case was ambitious to a degree, but when the rest of the province is on Epic platform for all of their care, those bits that aren't are a greater risk. So we've got a few places that aren't on it, and the risk becomes greater. I think there are complex problems around monopoly suppliers and procurement, and I do know that the trusts that own GP practices by default are asking us the same question that you've just asked. Can we not be on this platform as well? And I just don't know that as yet. But there would be some willingness, but you're going into areas of procurement that would be beyond my pay grade.
I get that. I think the department needs to take the responsibility of that, I'm just saying. So I'm going to keep asking it. So I'm going to keep pushing this. I think it is important, and I don't think the GP the responsibility should be put to them. I think the department absolutely needs to work out a way to do this going forward. And I mean, you've said that this kind of 11-year sort of lifespan for this particular system, so no good getting it in 6 years' time for 5 years. So I'm flagging it up. I don't expect all the answers today, but I am going to keep coming back to it, so expect the answers at some point. There are a number of other issues that I had raised yesterday. I forget what day it is today, Thursday. So yesterday at the CARES APG, just in relation to CARES, and there's some good things in terms of Encompass, just to make people aware of, where they are going to have the capacity to, put flags on to say somebody is a carer. It's just about how we make sure they identify as a carer and that is flagged, and there's potential to put further flags on. All of that is really, really good stuff, and I think even the potential for a flag around somebody who is just given our focus at the minute on the palliative care around where somebody is a palliative care or end of life patient, which could resolve some of the issues that we have around some of the challenges for those individuals and their care. I think that's all positive. One of the things that I did raise with the Carers APG was, can we get a list of what can be flagged on it currently, so that we know, if there are other things, particularly through the committee here, APGs or people that we're hearing from, is there something could be added there that would be really beneficial to yourself and others? And my last point is, Encompass is a great opportunity for information, data, statistics, but we need to get it. There cannot be a blockage through SPPG where it goes to them, and let's not give it to anybody else, because it might actually direct money where the services are required. That's not on you, by the way, but we need to get that information.
I talk about the Care of the Dying pathway. We have the Respect pathway built into the system, but we have not turned on because we still need to work through that in the Department of Health to release that. Hopefully that will be soon. Well, what's currently happening is people go through the Respect process and are similar to that, and then once they're discharged, that drops off. So then people have to go through the process again and again, and we have it built in so that doesn't have to happen. But we can't turn it on until we get the policy and procedure. The other issue, I think, if you can answer them all, I think, sorry, could you remind me the other one you were asking about?
Flags and alerts.
Oh, the flags, yeah.
So the list of flags that are currently on it.
Yeah, we certainly will give you that. A lot of that's with social care, and we have flags, and we have a thing called behind the glass or break the glass, and that's often used in social care, but it can be used for other issues and sensitive care. And we have proactive audit so that we know who's looking at information. Are they a member of the care team? Do they have the same name as the person? Do they have the same address? So it's a very sensitive tool. In the past, we had information governance based on paper, and to be all honest, it was impossible to audit. We now can audit all this stuff. So we're developing a framework to tell staff how to behave and the consequences of not adhering to expected professional behaviour. We'll take it away, and I think part of the issue, this has been developed from our point of view, from a healthcare point of view, and we have a 32 patient engagement council, but it's very difficult for them to understand it until it's up and running. And I think it's really important that we have a vector to say, why don't you do this? Why don't you have that? Because we can't talk about engagement and not actually take it on board.
Could I make a brief comment just about the flag and alert thing? Because I absolutely understand your point about understanding what's there and what the capacity is going forward. One of the things we do need to be mindful from in terms of the sort of international research to date is things called alert fatigue, where the extent to which that can have an adverse impact on clinicians, where you get an element of snow blindness almost in relation to it. So it's an absolutely important conversation, but it's also a conversation which highlights the fact that it's a management of change programme, it's a set of conversations, it's a cultural change. None of the switches will go on and off without the depth of the dialogue that Dermot's alluded to with the professional audiences, with the patient audiences going forward.
I really appreciate that last. This is a point, not a question. Just one of the issues that came up was some results will not go on to Encompass, and rightly so, and I understand the reasons for that, where they're very sensitive results, and that's not something that you want to put onto a system to be shared with a patient without a conversation. But is there some way of putting something up to say, contact the consultant, contact the secretary, contact your GP? Because if nothing goes up, that could be frightening too. Yeah. That could be like, why is that result not went up? Does that mean that I have it?
We have time frames for when things go up, but patients know if they don't go up, that could possibly be a bad news. So we're very clear that the app doesn't replace proper medical and nursing care. If somebody has bad news to hear, that's done face to face, that's done in a supported way, and the information can follow. But I think with very limited functionality turned on, and I think we will go down this pathway to expand what we do, but we will do it with our patient engagement council. Most of them they're there for a specific reason, and we will test it with them whether they think is appropriate or not.
Okay.
They would say to us, "You're far too conservative. This is my information," and I think they have a point. To be honest, I mean, the healthcare provide healthcare, but they don't own their information, and it is a wee bit patronising.
Me personally, but everybody's different. You see, I would think, just give it to me. I want to know. But not everybody's like that, so I totally understand you have to be conscious of that.
Paul?
Thank you, Chair, and good to see us again today. We had a good visit this morning, and I think we got a good look around the system and see how it works. And I know certainly in this parish here, I think I was the first MLA to have caseworker, and I think almost every MLA has caseworker now. I've had it nearly 9 years, and I just see the benefit of being able to use information, streamlining information, getting flags, as opposed to having lots of paperwork around in folders and files. So I wonder often how elected representatives managed before it. But the system is that there's just two points I wanted to make. Number one was we obviously got a tour today, and there's no way in a disparagement to them. It was a great tour, and I thank them for organising it. But of course, you get brought to the good. This is our brilliant people that love it and think it's class and it's great. And I do know there's been a number of staff over the transition period that would have said to me, "It's a flipping nightmare, and I absolutely hate it, and I can't get it." So I'm just wondering, is there still really good, robust opportunities for people if they can't get it's just not working, it's not doing what it's meant to do, that they have those avenues? And I think there was a slide this morning that you showed us where there's almost no apology for sort of saying this just isn't working and isn't right, but there is definitely still an opportunity for people to be able to flag up where they feel the system isn't working for them, rather than just being told get on with it. Is that still there?
The slide didn't say no apology, it said the power of apology.
Okay.
no
I'm sorry. I'm sorry about
Nirvana record from that, yes.
No, look, some people are zealots for this stuff. And some people just don't want it, and they want to treat patients. They want to be a nurse, and we have to modify our training to do that. And I'm not saying the programme the trusts have. So we would have the very standardised American training, all day in a room with a computer. It's really, I think it's mind-numbing. So they didn't think that was good enough. So what they did was they set up what they called user labs. So they would take scenarios in the ward if it was putting up drips or giving medication, and they worked through those. So the Northern Trust did it first and foremost. Well, Belfast did a bit, but Northern Trust did 14,000 seats, and the Southern Trust did 14,000, and Western Trust did 12,000. So we've changed the training to say we'll train you with your colleagues, like you work in the ward, not sit at a computer, and we've also, for the consultants, we've done a thing called personalisation, which has shown them all the tricks, the shortcome, how do you take away the drudgery? And we've tried to do that in advance of going live. So in the Southern Trust, about 85% of the consultants trained to that level before going live. In the Western Trust, 88%. And nobody heard across about the rest of the world those levels. So I think that's a testament to the staff who want to do it and want to do it well. But it is a radical change. We don't have digital dictation, voice recognition, and we would have liked that, but maybe it's a good thing because the technology's moved on. So we're doing a pilot of ambient technology where you and I come into a room and have a conversation, and that is automatically fed into the platform as itemised data. And that's pretty standardised technology elsewhere, but we obviously have to take that through information governance and a pilot process. There's lots of opportunities, and our Dutch friends are much further ahead than us, using large language models, using automated scribing, so that you can focus your time as a nurse or a doctor or an AHP with the patient, and the data goes into the system. And that makes you more efficient and effective, but it gives a better quality of outcome for patients. And I want to sort of an anecdote. The Dutch have published this in the Lancet, where they compared consultant level summaries against AI level, and they were of equal quality. But the patients thought the AI ones were more empathetic, which if you're working in a stressed environment, I can sort of understand that. But these are the tools that are there. But our colleagues in England are doing, say, ambient technology at outpatients on the basis, we'll use this, but you see one extra patient. So that's maybe an 8% increase in productivity at outpatients. And that's the kind of conversations we're going to have, because there isn't any more money, but can we work smarter and get better outcomes? So
there is a capacity for staff to feed in if they feel that something isn't working to work.
And I think you're also highlighting the fact that there's this concept of work as imagined and work as done. So whatever you're actually doing through that design stage and however you're adopting the practice of others, until you have the live and breathing experience of running that system, there will always be things that you then want to incorporate those changes. And there is a very elaborated governance process to establish the value of that change, whether some of those changes are actually a training deficit, to your earlier point, or whether they are, hold on, we were really well intentioned, we thought this was the right way to do this, but actually there's a tweak or a twist we need to incorporate going forward.
Good. And look, just finally, and it's not again a criticism of the system, but it's a slight frustration maybe up at this side of the process. Waiting list figures, we can't give you this period or that period because of Encompass. The number of people that are accessing service, we can't tell you because of Encompass. It seems it did feel like a little bit of time, not maybe from yourselves, I'm going to blame the Minister on this one. It felt maybe like the department was just, it felt, I know it wasn't, but it felt like it was just being used as an excuse not to tell you. But if there are data gaps because of Encompass, is that a data gap that can be retrospectively filled? So in other words, in a year's time, will we be able to look back and where we were being told at the time, we can't tell you what the waiting list is because of Encompass, will that be retrospectively filled, or is that information lost and gone forever?
I think it's a very salient point. And I think we have to put our hands up and said the due diligence around what Epic delivered in terms of NHS data isn't good enough. And we've had that conversation formally and have written to them formally, but they didn't tell us. And other trusts have had this experience. So when we go live, we have to look at all the data, and then we have to go back to the staff who are exhausted and say, what does that look like? And can you validate all that stuff? And traditionally, the data just came out of the system and our staff weren't involved in that process. So that's been a struggle. Now, we have out-of-the-box tools that are working really well, and I think you saw that today. At the same time as going out for the regulatory report and the SCPs, they have now changed to strategic outcome measures and framework measures, SOPs and SOMs. So as well as managing the validation of that, we're changing to a new thing. A very similar thing, but often slightly different. So the data is not where it should be, and it's not where we would like it to be. We will retrospectively put the data up, but we've agreed remedial work with the vendor Epic, and we have sort of an enhanced team resolving that. Now, I think the South and West will be in a better place, and that just shows that if we were told, we could have learned we didn't have to be in this place. So, I mean, it's not good for us, but it's certainly not good for a vendor, because when people come to us to say, how did you do that? What have been your problems? I have a list of things the vendor didn't tell you.
And it's really important because data drives nearly everything. If we don't know how many people have cancer in a particular place, then we're not going to be able to tailor the resources that go in. Or if we don't know the number of people waiting somewhere, then we don't know how to be able to go in and tweak the services. But it's good to know that it's flagged up, that it is an issue and that you're trying to resolve it so that we can get behind that.
In terms of cancer, we have all the local MDTs and the regional MDTs up and running on the platform, and everybody can see the information, one record, so there aren't silo informations, and so every professional who's providing multidisciplinary care has access to information, which is a big enhancement in governance.
Thank you, Chair. Thanks.
Nuala?
Thank you very much for the presentation today. I'm going to focus specifically on performance, post each trust going live. And I do think it is a great system, and we do have to move with the ages and update as we go along. Hopefully there isn't much money required for every time it needs updated, so that we're not years behind, because we could find ourselves catching up and then 10 years time, we've another time to catch up on. But I understand the difficulties with technology. I also hope that the kind of ambient kind of voice recording understands the different Northern Irish accents that we have here. That will be interesting. But with regards to performance, and specifically the South Eastern Trust, in the report it said that general surgery, breast, obstetrics, gynaecology, neurology struggled to return to full capacity, described as underperforming, and talks about performance, plans and improvement. It doesn't mention which ones specifically, but Why have they struggled? I think it would be important to highlight that Encompass is why, because if you think about Encompass as a computer system, but does that mean they have struggled in terms of their face-to-face meeting, their face-to-face consultants, waiting lists, or surgeries? What is it?
The initial trust struggled because often people would write short notes, but once you standardise care, there's a minimum standard of information that you have to put in, and that's probably more than some services did in the past. In breast services, for example, it became a linear system. You came in, you saw maybe a breast nurse, then you went and had radiology, and then so everything was done in a linear fashion. In the previous days, people were doing asynchronous work and working at many tracks at one go. The underlying learning from that was that we didn't plan for the upturn properly, and again we had deep discussions with the providers, and when we went live in the Belfast Trust, we'd done basically what we called a playbook, back to green activity playbook, and we were very directive about what we had to do. When people struggle on the platform, it's because often they're not putting information in correctly, and it slows them down. So the resolution to that is to have professional leads in straight away to help teach people. You're dealing with a bit of psychology here more than IT, because you've got people who are expert in what they do and they're floundering a bit and they don't sometimes ask for help. But as soon as we see a downturn, that just should mean that people are struggling in getting the activity down. So we've improved with the Belfast Trust. The Northern Trust was better still, and the South and West are much, much better, so their downturn will be markedly less. Once you
downturn and upturn, do you mean like physically seeing and treating?
Sorry?
Or the use of the data? Or the use of the system?
I'm talking about the activity on the system.
Yes, yeah. Okay. And well, in the report it says struggle to return to full capacity and described as underperforming. Is that full capacity in meeting and treating patients, or full capacity in usage of the system?
It means activity. So say if you'd seen 15 patients for outpatients, it's maybe they struggle to get past there. And the South Eastern Trust is now back to activity, but one area they did struggle in was antenatal clinics, because the consultants in Northern Ireland do their own ultrasound scans, which is quite unique to Northern Ireland, and so that's an extra task that they were doing, which just added to complexity. And sometimes when you do an implementation, you find things that are that's a Northern Ireland variant, which we'll probably have to address in the long term, because we'll have to ask why that's the way it is and why we're not similar to everywhere else.
And the consultants that carry out and treat the patients, they usually have people that assist them, in their notes and everything. And is that now, are we talking about everyone having access within the consultants team to do it? We often, as elected representatives, we contact consultant secretaries for information and stuff. So. Well, do they also have access to enable, like, basically you get on with the patients?
There's role-based access, so people should only be accessing information if they have those rights.
Of course.
The secretaries may have those rights if they're delegated to them by the consultant under a proper information governance structure. I think the issue about this platform is it's one platform with people can access, but it can only be accessed if it's inappropriate.
I think you're highlighting the fact that actually underneath clinical processes is a huge amount of administration.
Yes, yeah.
Effectively. And that has to be factored into all of the preparatory work that you do. Colleagues who visited this morning, I think, saw the full spectrum of who has access to systems and how do they use them. They met the converts, they met the reluctant converts, they met, and it is that spectrum. I think focusing in on the clinical relationships and roles is really important, but one of the tariffs that, again, looking around these systems globally, that doesn't get expressed to the same extent often as the volume of administrative work. And that, I would say, Dermot's experience is reflecting what others have, which is capture that and then roll that insight into the next deployment and the next deployment.
The way we manage the data is in these things called work queues and the information about patients. And when this South Eastern Trust went live, they suddenly had 3,000 of these things. So it is very complex work, and the Belfast Trust probably had over 4,000, and so you can imagine that the staff learning a new way of working and a new type of working.
And is the aim, well, I know the aim, efficiency and update data and technology and patient access, but is one of the aims, and will it be, as a result, being able to actually see more patients and you know, get rid of the burden? And are we seeing that anywhere yet, or will it be some time? If others are, you said the South Eastern Trust is now up to performance from post going live. Okay,
but
so
some
it's
time
a
ago
bit,
now. I mean,
well, I know just in the report that we have says that it wasn't. So it's good to hear that it is. But are you saying?
I'll give you some examples, and we're just starting to do this work because we were focused on going in. But an example from the Northern Trust, the CDIO, the medical clinical digital lead there, is a children and adults psychiatrist, and he was very concerned about the backlog on autism. So he's building out the autism assessment on the MyCare app so that patients and parents can do that asynchronously. So when they come up for their assessment, all the information's available, and they can have a meaningful conversation. And there's lots of examples of other places. Like, has anybody been to a fracture clinic after a fracture? It's a bit like Third World, it's a bit like a World War, and there's 30 people at a clinic, and said, "How are we going to do this in the platform?" And the question was, why would you do it the same way when you've got an alternative way of doing it? So you can review X-rays and say to people, send them out patient-reported outcome measures on the app and say, do you need to come up? And that way, certain people, you can stream out what you're doing instead of one size fits all. So it's not, productivity is not just going to be more of the same. It's going to be thinking of different ways of doing it, and ways that patients will accept.
Thank you.
Thanks. Alan Chambers.
Thanks very much. A lot of the stuff I was going to ask you have alluded to it, but I like that phrase, the end of the beginning, because it helps me appreciate that it made so much sense, that a lot of the energy and effort was obviously been directed towards the rollout of the system and working out the glitches. But the MyCare app, I think it's a critical part of the system as well, for the system to really provide the benefits that it can do. It'll obviously help to reduce the unacceptable number of missed appointments. It'll reduce the number of phone calls patients making to consultant secretaries or to their GPs to try and get blood results and stuff. So that app really is, as I say, it's a critical part of it. Now, I know you said that at the start that in terms of advertising the app, there was sort of a light touch, but you didn't want to be swamped. That because of all the energy going into rolling out the scheme, but we're now at the point where I suppose, yes, there is going to be renewed energy and a push to get people to register for the app. I also appreciate that when people are applying, that you have to protect patient security and integrity by asking a lot of questions. But I found the registration process quite challenging at the time, probably not helped by the fact I didn't have any of my primary school grandchildren beside me who would have helped me out greatly. But what I found about it, if my memory serves me right, is that it got a bit frustrating, because when I got sort of, I don't know whether it was a third of the way or a quarter of the way or half of the way through the registration process, it started to ask me for information I really would have had to go and search a house to find. Whereas if I'd have known you need your patient number, you need this, you need that, date of birth's easy, but all that other stuff. So if you are making a push, maybe, as I say, maybe I missed it, maybe it was there and I missed it, but if there could be sort of, before you start this, here's what you need, and then it'll be an easy process, and I think that would help. But as I say, I think, you really do now need to get the patients on board. But just wonder, just a figure, you may not have it, but What's the sort of figure of uptake of the app?
It's
at the
167,000.
67.
162
and two.
Look, could I say, I apologise, but what you just described is 100% correct. Well, it's a NI Direct pathway, and we just assume people know how to do that because they did it in COVID 4 years ago, and that's kind of stupid. And you need to go in, you need to verify who you are, you need your passport, and it's a very secure way of getting in, but it is very difficult. And not everybody uses this methodology in the UK, but we thought it was a very secure way, especially if you're maybe looking proxy access and information like that. But we need to do it better, and I think there's no point in us saying to you, would you champion this? We need to champion it, and we some staff who maybe are changing jobs, we will ask them to be MyCare champions, maybe at outpatients, because usually people go on the system when maybe they're up for an appointment, and they should be guided through that. And maybe we should tell them, look, if you're interested in getting this on, make sure you've got photo ID and stuff like that, and we could help you do that. But this won't happen by osmosis. We have to have a program plan around it and staff and infrastructure to drive this, because if we're hoping to change care using this app, you don't want a disadvantaged group sitting left out and not being able to be part of the change just because maybe they're not digital literate or because we haven't given them enough help and support. I can always think, would you prefer to have some of your information or your appointments virtually instead of maybe driving to Belfast and waiting a couple of hours for a car park? And I'm not saying that's how care is going to be for everybody, but there's lots of opportunity to improve it.
Yeah, we'll probably all miss saying this, but congratulations on what you've achieved so far. It's been really superb effort. Thank you.
Wasn't us. It was 80,000 staff, and I keep saying this, 15,000 of the staff are what we call super users. These are people who volunteered to do extra work for no pay. And because that meant that every 1 in 5 members of the staff was a super user. So when you were having a bit of difficulty, there was somebody at your elbow. And it was just incredible to see, because everybody was incredibly difficult, or everybody was incredibly busy, and it was. I've been in the health service a long time, and it was just amazing to see, and just
Well done, everybody.
So, just in terms of the MyCare, because I can remember what you were saying at the time of signing up for the NI Direct, but this morning I literally my device had all of that stored. So I was able to go to MyCare within 30 seconds with no difficulty. Now, I obviously
no grandchildren to hand.
No, stored it really well. So once you sign, it's an NI Direct signing up process that will be slow and cumbersome. I imagine a lot of people will have those details already stored in your phone.
I did help my son get onto the MyCare app on Saturday. And there was a bit of bad language between the both of us.
Okay, so we've 2 more left. We're beyond our time limit. So quick questions, quick answers. Danny?
Thank you very much. I declare an interest here as an Encompass user. I've been a nurse previously. When I started nursing many years ago, it was all paper. And we've moved slowly towards the digitisation. The training that you described, I was South and Eastern Trust, and the training was all classroom based, and it was very hard for a lot of nurses who weren't really sort of very, very computer savvy. It is incredibly digital. Every aspect of the job changed overnight. Even taking blood, there was new steps that became involved. You were given new pieces of equipment. There are huge benefits, certainly the patient safety. Using a rover means you can't give a drug to a patient by mistake, which is fantastic. There's a lot of patient safety things there that are very good. Certainly, I've seen a huge uptake in staff being able to use it. Initially, when I was going in, I go in for bank shifts, and it was a big change, and everybody was kind of adapting to it, following the training and things like that. Now they're flying, absolutely flying, and there's ones coming out that had wished that it had always been that way, and see it as a huge benefit. So certainly, the job has changed, but there are huge benefits with that. Certainly a lot of people would do that. Apologies for not attending the visit this morning. Unfortunately, I had another engagement, but I would have liked to see that again. Although probably would have been very familiar. One thing did strike me when you said the due diligence around the NHS data wasn't good enough, I think was the term that you used. Is it doing what it was promised to do? Are we getting the data that we expected?
The out-of-the-box tools to manage day-to-day work well, and part of the deficit was that we needed to train everybody and educate people on that, and the assumption that people would somehow magically be able to do that was erroneous, and I think that was a shortcoming. There is other data, regulatory reporting and service delivery plans, which we then have to take out and validate, and the frailties in them is that assumes that people are putting the data into the platform in the correct way, and it's unlikely that people will do it 100% correct in the first instance. So you do need validation, has to go along with the digital teams going around and checking people that they're doing that correctly. So it's a long process. We've got what we call sprints going on around the out-of-the-box tools, and we think that they're done, and that's been well received. But we're still working on the validation, and we're doing returns, so we're stepping through. Because it's the same everywhere, if we do it in one area, we can lift and lay that for another area, so there is a bit of benefit in that. But at the same time, we're redefining what I call these new measures, softs and SOMs. So we're working both with the trusts, the data teams in the trusts, the SPPG, and the information groups within the Department of Health. It is a complex piece of work, and I think it's not something that we've done as well as we could have.
Okay. There is a basic constraint of quite a lot of the US-based systems where that sense of almost the right-hand drive, left-hand drive model, if you like, we're having to shape some of that data to serve purposes that would not inherently be the demands that are made in a US-based model. So we're not focusing obviously on price, because you don't walk out and somebody give you a bill for your treatment. Some of those things are intrinsic to the way in which this product or other products that would compete against it are built. Some of our expectations about concepts like queuing are not necessarily as fundamental in the US system, because it's not expected to that extent or degree. So some of that stuff that you're talking about and Dermot's highlighted is where we then progressively shape the outputs with the right people and the people who understand what we're looking for, to make sure that then going forward is what the system does routinely and automatically.
When will we?
It's a progressive process, isn't it? It's a rolling process.
Our aim is the end of August. I should say the vendor have done an NHS data framework. But that's for HSE England, and while we are almost similar, we're not identical, and it may be not possible just to lift and lay that.
One other question, Chair, if you don't mind. 300 million cost of Encompass. We were estimated 300 million now. So that's 3 maternity hospitals, for example. So there's quite a big price tag to that.
Build them.
Sorry.
Give the name of that builder.
We were told now it's 360 million.
Yeah.
So there's an extra 60 million. And 11.5 million a year from now on. Is that the correct pricing? So what was the extra 60 million, and why has it increased so much?
I fess up to that, and I'll take responsibility for that. When we came in, not in totality, when the programme started, it had approximately 50 staff within trusts to deliver this work, and that would be, if you divide it up, twice for Belfast, and that's about 8 staff in each trust, and maybe 16 in Belfast. Belfast alone has 24,000 staff. That would not have been successful. And at that stage in 21, we had a discussion with the Economic Department and the Department of Health and the Department of Finance to see if we could expand that, and we expanded that to about 250 clinical staff, and that's extra nurses, extra doctors, extra HP staff, extra social workers to lead this as a clinical transformation. It's not really an IT We're doing one thing, we're standardising care, so we're changing the pathways for everybody, and then we're putting it onto a digital system, and that additional resource was additional staff for a period of time. The programme has a life of 13 years, so it's not plug, play and decay, it's plug and it'll be with you with the resource for the next 13 years, and the resource is almost 200 people. So what that allows you, as you need to change services, as you need to shape, as you need to transform, we have the build teams, we have the training teams, we have the business change teams, and we have the clinical expertise. So this isn't, we're here now and we're going to do one thing. This is a generational change, and it's an investment over a very long period of time. But it'll only be worth the money if we do the change. It'll only be worth the money if people come back and say, well, that was good investment. I mean, I think 360, if it delivers what it needs to do, is better than 300 not delivering, I'll be honest.
Just so I'm clear, the extra 60 million was additional staff time?
No, additional staff numbers.
Additional staff numbers?
Yes. We were implementing in I would say, a system running hot. So we needed to get people out of those jobs to give them roles. So we have digital leaders in social work, digital leaders in each trust, in nursing and digital safety nurses, a range of staff to make sure that we could do this effectively, efficiently, but also safely. And those roles are now become, they were there for three and a half year period, basically, to get us over the build and the delivery. And some of those roles will be rolling off.
This hadn't been foreseen by any of the other previous rollouts in other places?
It wasn't in the initial business case, and I think it's not unusual for business cases in IT, and I'll ask Paul on this, not to be. They often focus on the IT bit. They don't focus on the healthcare change and the transformation bit, certainly this formed part of my discussion. We have a lot of people coming to see us to see, how did you do this? And we have pretty standard talks, and we talk about transformation, clinically led, digitally enabled, and you do need the clinical leadership. And anybody who's there this morning maybe met David Wilson and Angela. They're very senior leaders, but people will not deliver this unless they own it in trusts, and that's what made it safe. And everybody says, well, they were very successful implementations. So they're successful because the healthcare staff are doing it.
Didn't we do that as well? Didn't we look at other places that had implemented it?
Yeah, and some of them didn't implement them as well. I think if you go back to the very first one in Cambridge, I think it's fair to say that's an epic implementation. It wasn't. This is a natural tension between a vendor saying it costs X, where you have to make an honest assessment, and I think we made a more honest assessment.
Yep. So my experience is outside of Northern Ireland. I've been here 3.5 weeks. The reality of the model that says if you build it, they will come is a very old school IT approach, particularly in the context of clinical systems that require change of practice that you've alluded to in terms of your nursing practice, change of practice, doctors, change of practice, etc., etc. I think no one would they? There is less risk of somebody undercooking, understanding that this is a transformation program now, than people thinking it's an IT program. If we leave no other impression today, I'd love you to forget about the word IT and embrace the word digital. And when you think about the word digital, think about it being about culture change, leadership, transformation, all those sorts of qualities. And to do that in a health and care system, you need the expertise and talent of the people that Dermot's referring to that were afforded in that extra buffer.
I absolutely appreciate this is a huge generational change towards digital healthcare, and I think that's to be welcomed, and there are huge potential benefits. My question was around an extra £60 million worth of cost in a context where budgets are very, very tight, and we are cutting other services at the minute. I appreciate that. I mean, so £60 million of public money. Sure. Extra,
I understand it. It's over a long period of time, and the benefits. I mean, the business cases of 512. Non-cash releasing, a smaller amount of cash releasing. We think they're very low. we would really like to think we would surpass that.
Time will tell.
And
In 11 years, let's say. No problem. Thank you very much for that.
Thank you. Alan?
Briefly, thanks, gentlemen. I have to say my own personal experiences of the My Care app has been nothing but positive. And that is as someone who is absolutely dumb to technology and all these devices, and I struggle to navigate my way through them. Half that I do not even know what they do. But I have to say, my experience was that it was easy to navigate through, and I was able to access scan results very, very rapidly and quickly, and it saved that Monday morning mayhem of ringing a GP surgery trying to access those results. So for me, that was the big positive for me, and I hope that is reflective of many others going forward. Just with regards to any piece of huge digital technology rollouts, there will be hiccups along the way. So on an individual basis, a staff member who has a hiccup along the way, how timely is that support? When I can hear when I talk about how difficult I find navigating through all these pieces of equipment that I have people upstairs here that I can lift the phone to and get quick and timely access in order to approve whatever problem that I may have. How timely, given how critical this technology is nowadays, how timely can they access support?
If somebody has an issue, they raise what we call a VFAR, and it's triage between P1 to P5. It's P1 to P2. It's done immediately. It's life-threatening or urgent. But they also have a digital safety team still in the trust, so they will be able to help them and sort them out on the spot. A lot of issues can be resolved locally because we have these funded digital teams within the trusts, and it's not just sort of like an IT glitch and wait and finish. We have had unexpected downtime for about 20 minutes once, and we have planned downtime, and that happens every 3 months, and it has a 4-hour window, and we've reduced that to an hour and a half. That's done at 4 o'clock in the morning to minimise. It's a very stable, because we've gone through 4 implementations. The patient pathways are now very, very stable, and there were glitches as we went through each go live, and when we go live we have a huge enhanced team. So while our team is the 200 I mentioned, we would augment that up to maybe 400 with people coming across from Europe, America, so that when you're going live and you know there's risks, you've got a huge team to fix them immediately. And as we went through this to the south and west, we set up regional meetings so we could discuss any changes we needed to make. We didn't need to use that team because there were no regional issues, and the pathway is now much more stable, and the numbers of issues are reduced. Now, that's not to say there's always things, but we have ongoing support, and we have 24/7 cover.
I'm not going to contradict something I said earlier, which is I don't want you to think about this as an IT program, because I think part of your question was at the basic level of anxiety of somebody when they turn on the machine and not doing the thing that they wanted to do. I think there's both that. So again, Dermot's given you a very comprehensive view of the system in terms of the workflows, the pathways, etc., etc. There are trust IT teams ubiquitously across all of the organisations who are there to address the first order question of this machine doesn't seem to be responding the way I want it to. There are training teams available to augment that as well. So it's a both and. If your concern is IT, there'll be somebody to help you with the IT. If your concern is the clinical workflow and the pathway, then the process and the mechanisms that Dermot's highlighted are what are in place.
3 minutes unexpected downtime is very good in the grand scheme of things.
And I should say we have a business as usual system where all the information is downloaded into freestanding computers, so you've still got access to that information, so you can still treat patients excuse me, but you wouldn't be connected to the system. But the downtime has been disappearingly small. Excuse me.
Fair enough. Gentlemen, thank you very much. really appreciate your time. We went way over time there, so that shows the interest that members had, and we will be in touch for an event. And
Great, thank you very much.
so thank you. So members, just following on from that, in terms of My Care, we did give a kind of a commitment today in our visit that to help promote the app to the wider public, that we would do some event so that allows MLAs who haven't signed up to know about it and sign up, and also members of staff here in Stormont, as well as doing the wider publicity thing. So if everybody is content, I'm just going to leave that with the staff to liaise with the department in terms of whatever event it is, and then keep us posted. Linda?
I mean, I'm happy to do that. I think it's a good idea. I think if there's a way of making it interactive, so don't have like a set piece event, where people come in and they talk and everybody's bored to death. No offence to anybody, but have it something more interactive, where it's like a stand where you could have organisations bringing people.
Yeah, to be honest with you, my idea is literally a 10-minute presentation so that people know what it is, and then have people helping others to sign up.
That's it.
That's
interactive, yeah.
That's literally what I'm suggesting. I mean, at the end of the day, it is about getting people to sign up and use that event to publicise it. So obviously we invite the press. So it certainly won't be, if we're trying to encourage MLAs and staff to do it, 10 minutes, here's what you do. If you need help, there's help available. Happy enough with that?
Yep.
Okay, so item number 8 then, back to oral evidence on the inquiry and access to palliative care service. So can I refer members tab 8? This is including clerk's memo, page 65. So can I welcome Michael O'Neill, Interim Director of Quality Safety Improvement within the Department of Health, Sally Convery, Palliative and End of Life Care Nurse Consultant within the Public Health Agency, and Diane Walker, Palliative Care and Partnership Programme Manager within the SPPG. So you're very welcome. Going to invite you to say a few opening remarks, and then we're going to have questions from members.
I'm going to open if that's okay, Chair. Just like to thank the Chair and the Committee for this opportunity to provide an update on the implementation of advanced care planning, which has featured in a number of sessions during the Committee's current inquiry. Today I propose a short briefing on the current position on some of the implementation of the policy, which is intended to address some of the issues raised by witnesses during the hearings. I understand departmental colleagues are also briefing the Committee next week on palliative care strategy and funding, commissioning and services and data collection. By way of background, the Department published the Advanced Care Planning Policy for Adults for Now and for the Future in October 2022, but despite the clear benefits, establishing momentum with implementation has been challenging in the period since. Advanced care planning is an umbrella term covering personal, legal, clinical and financial planning. A core aim of the policy is that ACP becomes normalised by increasing public awareness and understanding of what ACP is, encouraging adults at any age or at any stage of life to consider and plan ahead for their future, including their future treatment and care. Between 2022, when the policy was launched, and April 2024, the Department engaged with PHA colleagues to establish the best approach to implementation. A task and finish group reported in April 24 with a proposed structure and membership for a project implementation team and priorities for an initial 18-month policy implementation phase. Progress since then has been difficult. The Chair and members will be aware of the significant resourcing pressures facing the Department and PHA colleagues over the past number of years, and unfortunately implementation of the policies had to be considered against a number of other competing priorities. That said, implementation of the policy remains a strategic priority for the Department and PHA, with the associated benefits clearly evident and understood across the HSE system. These include enabling individuals to express their wishes regarding future medical care, thereby importantly ensuring their wishes, beliefs and values are accorded the respect they deserve. Consequent benefits to the HSE system are also evident, for example, potentially reducing hospital admissions through more efficient and effective use of resource. Against that, the risks of not implementing the policy could mean that individuals are not empowered nor afforded the opportunity to have decisions on their care supported by a record of their wishes, beliefs and values, and as a result care is less likely to be proactively managed and coordinated. The Department acknowledges that the continuing absence of the delivery of a clear and structured implementation plan is frustrating for the HSC and stakeholders, and we have heard this perspective raised in sessions during the inquiry. Members will be aware of the Minister's correspondence in May and June 2025 to the Committee regarding advanced care planning policy. He outlined that some progress should be possible as part of our wider winter preparedness plans, which demonstrates Minister's commitment to what we all acknowledge is a very important area of work. I understand the Department are briefing the Committee on planning for winter preparedness on the 18th of September, and that a written briefing is also being prepared. By way of an update since Minister's letter, I confirm that advanced care planning has now been identified as one of the 8 priority work streams for consideration under our winter preparedness programme. Work has started in recent weeks to establish an advanced care planning project, and that work will continue at pace in the coming weeks and months. This is an important first step, but it will of course be equally important that the implementation is progressed in a managed way, and that some of the inevitable challenges around the system readiness, training and resources for instance, are worked through, most likely with a pilot phase before they are scaled up and applied more widely. Timely communication with the HSC and wider stakeholders has also been identified as an early priority, and as the work takes shape and in order to keep everyone appropriately informed through consistent messaging. Successful and full implementation of the advanced care planning policy is a significant task that if we're to do properly will require an ongoing dedicated resource. Most importantly, it will require a societal shift to ensuring advanced care planning discussions become the norm rather than something that's to be avoided. In summary, there's a common agreement that advanced care planning is the right thing to do, primarily for the individual, but also for the wider healthcare system, and prioritising implementation in this way will reintroduce momentum in this area of work. If the Committee is content, I would suggest that the Department provides a further written update on the proposals when further initial planning has been completed by the project team and they have mapped out a timeline for the work to be progressed. I will now pass over to Deanne for her opening remarks. Thank you.
Thank you. Good afternoon. Thank you for this opportunity to provide this briefing on behalf of the Palliative Care and Partnership Programme. My name is Diane Walker and I'm the Palliative Care and Partnership Programme Manager based within SPPG, and I'm also the Macmillan Palliative Care Transformational Lead for Northern Ireland. I'm joined today by my colleague Sally Convery, who's the Palliative Care Nurse Consultant at the Public Health Agency. In 2016, the RQIA undertook a review of the implementation of the Living Matters, Dying Matters strategy and made a number of recommendations, which included that the Department, in partnership with stakeholders, should develop a new 3-year action plan for adult palliative care. Co-chaired by the Health and Social Care Board, now SPPG, and the Public Health Agency, the Regional Palliative Care and Partnership Programme was established as a single programme to support the continued implementation of the Living Matters, Dying Matters recommendations. The partnership membership reflects the collaborative ethos of good quality palliative and end-of-life care, recognising that palliative care is everyone's business and requires proactive and integrated working across secondary, primary and community care, and in partnership with the person, those important to them, our hospices and the wider voluntary and community sector. Our structure consists of an overarching regional programme board, a multidisciplinary clinical engagement group, 5 palliative care locality boards coterminous with trusts, and our Voices for Care service user and carer group, some of whom I know the Committee met with recently. Together we work to deliver a regional palliative care work plan based on existing policy and constructed around key priorities which are agreed collaboratively by our membership. In 2023, the programme undertook a priority resetting exercise to set the programme's direction for the next 3 years. Following extensive engagement, our partners agreed 4 key priorities to guide our regional work plan through to 2026. I would like to take a few minutes now to highlight these priorities to the Committee. The programme's first priority is early identification and timely intervention. Around 1% of the population are considered to be in their last year of life, and research suggests between 75 to 90% of those could benefit from a palliative care approach. Many of these people will have been living with long-term non-curative conditions such as COPD, heart failure, advanced cancer or dementia for a number of years and have reached the stage where their health is naturally deteriorating to a point where death can be expected. Just over 17,000 people die in Northern Ireland each year, and on this basis it should be possible to identify around 13,000 to 15,000 of these patients who would benefit from a palliative care approach. Yet system-wide identification of people likely to be in their last year of life is historically poor. When patients are identified, it is often those with advanced cancer whose disease trajectory can be more easily anticipated than other conditions. This is demonstrated by local data which shows that around 90% of patients admitted to our hospices are cancer patients. As cancer deaths account for less than 30% of all deaths in Northern Ireland, this leaves a question mark over the identification of people who die from other conditions and if they are being identified early enough in their disease trajectory. Or are they presenting late with symptoms and circumstances so complex that intervention from specialist palliative care is required from the outset? Regardless of the condition, early identification of those likely to be in the last year of life provides a number of benefits, including the opportunity to have brave and honest conversations, to ensure the district nurse is engaged as the palliative care key worker, and to plan care in line with the person's wishes, whilst taking account of their individual circumstances and what may or may not be possible to achieve in their final months, weeks and days. Failure to adequately identify people who are likely to be in their last year of life reduces our ability to anticipate and respond appropriately to their individual palliative care needs. It also increases the likelihood of crisis situations, attendance at ED and avoidable hospital admissions, which come at considerable cost to the system and, more importantly, result in poorer experience for the dying person and those important to them. The programme's second priority is to work with our palliative care locality boards and providers to facilitate improvements in the coordination and quality of local palliative care pathways. Many of our member organisations and professional colleagues have already appeared before this committee and provided evidence about the variance of services across local geographies. You have heard from previous contributors the vast majority of palliative care is provided by core health and social care teams, GPs, district nurses, AHPs, social workers, pharmacists, those working in hospitals, care homes and the home care sector, and professionals working across other long-term conditions or specialist pathways such as respiratory, cardiology, learning disability and cancer. You have also heard of the continued pressures across the HSC system, including access to GP services, waiting times for outpatient appointments, lack of 7-day services and issues with availability of care packages. None of these issues will be news to you, but they become more pressing and distressing when you're a patient facing a terminal diagnosis who has unmet needs or uncontrolled symptoms on limited time. The regionally agreed palliative care pathway provides a roadmap for those people who have been identified as likely to be in their last year of life. However, given the variation of core service provision, access arrangements, referral processes and staff capacity, like many elements of health and social care, this can look very different depending on where the patient lives or wishes to be cared for. Under this second priority, the programme aims to support standardisation of guidance, encourage the streamlining of local process and facilitate the scale and spread of innovation and good practice. Within our work plan, there are currently 34 work streams under this priority. Whilst I cannot cover them all, I'd like to highlight a few which will hopefully demonstrate the ambition. The programme has facilitated the development and distribution of regional guidance for the management of symptoms for adults in the last days of life, including specific guidance for managing diabetes, for managing heart failure and regional opioid equivalents. My colleague Sally has recently led a project which develops standardised guidance for the management of syringe pumps, ensuring similar practice will be adopted across all care settings and importantly, ensuring all patients with a syringe pump are provided with a standard patient information leaflet. The programme coordinates the NHS benchmarking national audit for care in the last days of life, known as NACEL. Recommendations from this were able to inform commissioning to ensure all trusts now have access to out-of-hours medic-to-medic specialist palliative care advice. Through celebrating local innovation and showcasing good practice, the programme has supported the scale and spread of initiatives such as just-in-case boxes, pioneered in the Western Trust and now adopted across Southern Trust and being progressed in Belfast and South Eastern. The third priority of the Palliative Care and Partnership Programme is the development of a regional framework to support palliative care education and learning across care settings. Education, training and development was a key theme of the Living Matters, Dying Matters strategy. However, over recent years, increased service pressures and competing priorities for training agendas has led to a reduction in palliative care training being prioritised across the system. Emerging results from the NACEL audit show staff in Northern Ireland have a lower level of confidence in delivering palliative and end-of-life care than their counterparts in England and Wales. Upskilling our generalist staff to ensure they have the skills and confidence to care for increasing numbers of palliative care patients is fundamental to future-proofing delivery in years to come. Equally, it is important to ensure undergraduate students have palliative care skills and knowledge when entering the workplace and that there are robust postgraduate education pathways to grow and succession plan for our specialist palliative care workforce. To drive this forward, a new regional palliative care education and training steering group was established in 2024, with membership drawn from across trusts, hospices, primary care, care home and home care sector providers, and incorporating the HSC Clinical Education Centre and our universities. To date, the steering group has identified 100,000 plus staff working across care settings who require some level of training as they regularly support and care for people with palliative care needs approaching the end of their lives. Over 50% of those staff are working in our care homes and home care sectors and within primary care. The steering group have recently agreed a draft regional education and learning framework across 5 domains of care and are mapping existing training offerings in an effort to identify opportunities for scale and spread and to spot genuine learning gaps. We're also working with our Voices for Care members and through Compassionate Communities NI to better understand the information needs of patients and those important to them, and considering the training needs of caregivers who are often providing considerable hands-on care to their loved ones at the end of life. Finally, the fourth and arguably most ambitious and challenging priority is supporting the public health approach to palliative care. This priority aims to improve the public understanding of palliative care, challenging perceptions that palliative care is only applicable to those actively dying or only for those with cancer. Promoting death literacy by opening up discussions about death and dying and advocating the benefits of advanced care planning at all stages of life. The public health approach is about involving the community as equal partners in the provision of palliative and end-of-life care and encouraging the development of compassionate communities who are willing and ready to support local people in practical ways as they approach the end of their lives. I referenced earlier the 13,000 to 15,000 people each year who we can anticipate are likely to be in their last year of life and who the system should be able to proactively identify and support. However, this is just one part of the complex picture of palliative care. In addition, there are estimated to be another 150,000 people across Northern Ireland who are living with long-term non-curative conditions who, by definition, would also benefit from a palliative care approach. These people may have many years ahead of them and are unlikely to identify themselves as requiring palliative care. Indeed, many of them, I am sure, would be alarmed to be referred to in this way. However, they are living with conditions from which they will not be cured. Their needs in this phase of illness are hopefully being catered for by core health and social care services. Ideally, they will also be considering their own advanced care planning wishes and the practicalities of those as their condition deteriorates over time. This large cohort of patients, who currently may not be recognised as such by the professionals who care for them or realise it themselves, are the last year of life patients of tomorrow. As a system, we need to get better at articulating this, initiating honest and practical discussions, empowering people to, when they can, play an active role in their own end-of-life care planning. If we don't get ahead of this, it is not inconceivable that unscheduled care and specialist palliative care services in the future will be overwhelmed reacting to crisis situations and complexity of care which the system should have seen coming. Hopefully, I have given the committee an insight into the multifaceted nature of the palliative and end-of-life care and the vision and ambition of the Palliative Care and Partnership Programme. Palliative care is complex. It is not only about treating physical symptoms but also attending to the emotional, psychological, spiritual and practical needs of the patient and those important to them. In this context, it is extremely difficult to consider where business as usual healthcare meets palliative care and who should be providing it and when, as this will differ from patient to patient dependent on their disease trajectory and specific set of circumstances. This brings me back to the ethos of our partnership. Good palliative and end-of-life care is a collaboration of professionals and services, individuals and communities, all working together to provide holistic support and care for people as all of us will, inevitably approach the end of our lives. To achieve this, end-of-life and palliative approaches need to be considered not as a standalone service, but integrated fully into the system through every long-term condition pathway, as well as being recognised in departmental strategies beyond healthcare. I would like to pay tribute to my fellow team members Sally and Saika and all of our programme members and partner organisations, many of whom you have already heard from during the process of this inquiry. The work of our programme would not be possible without their continued support, passion, challenge and professionalism. I am privileged to see firsthand on a daily basis how much they care and are driven to do what is right for the patients and populations they serve, within limited resources and the competing priorities of health and social care. Sally and I are happy to answer any questions you might have about the programme and its work. Thank you.
Thank you. You outlined 4 programme priorities and identified lots of gaps currently. System identifications per training for staff required, raising awareness within the general public, etc., etc. Can I ask, in terms of the work of PCIP, how, and the 4 priorities that you have set out, how does the department evaluate that work?
Okay. So obviously the priorities are very different. Some of them, and I suppose some of this comes back to data and metrics. Identification is difficult to measure in the system at the minute because the data that we have in, and I believe you just had a briefing on Encompass, the data we have at the minute doesn't speak to itself, and because palliative care is provided across our organisations that are not always within HSC, so our hospitals, etc., it's hard to link data sets. So we have been working with Encompass to make sure that in the future the palliative care minimum data set will be built into Encompass to enable us to do that, so that there's a difficulty in evaluating that, obviously at a patient level at the minute, but we hope to address that. The coordination one is really down to how that looks at local level, because the palliative care pathway is regional. The local processes will have to be different to be able to manage that, and that is down to patient experience at local levels. So that is measured by things like the NICEL audit at the minute in hospital care. Our third priority, the education and training. I say that's something that we are really trying to get a handle on. So there are certain metrics which we can take from some of our trusts around the education that is currently provided. Again, some of that is taken from NICEL and shows that there has been a considerable drop in the mandatory and priority training of end-of-life care over recent years, which is one of the reasons why our Palliative Care and Partnership prioritise this. And the third one, the public health approach to palliative care, well, hopefully I demonstrated how large a piece of work that is, but and it is difficult to measure some of that, but we would use the likes of the I survey every year, which measures public opinion of palliative and end-of-life care, and the Life and Time survey that Queen's run every couple of years around those sorts of things. So in short, that was a really long answer, but in short, it is difficult in some of these areas, and we do want to get much better, and these Encompass will help us in that, we hope.
Encompass will help. I mean, we're obviously, as part of our inquiry, when people are coming to give us evidence, the scoping exercise has been the focus of a conversation. That's not, you aren't involved in the scoping exercise because it has come in for some criticism in terms of who actually has been scoped and the length of time that it's taken.
So my colleagues are coming next week. I know they're coming soon, but I have certainly been involved in that piece, and so is our Palliative Care and Partnership programme.
Okay.
So if it's okay, I'll let them answer
those
specific questions.
Next week.
But I mean, there's absolutely a link there, and we are very much involved in that. And part of that is really, we see this as a real opportunity, and we want to do it right. So part of that is making sure that we are asking the right questions of the system.
They will get hard questions next week.
They will be absolutely ready for them, I hope.
So, I mean, in terms of the work then, is there a budget assigned to the work, and how much is it?
Palliative Care and Partnership?
Yeah.
There is no budget, unfortunately, assigned to
so that goes back to the point that Michael made, and is that, like whenever the department are prioritising, your work will sometimes not be prioritised whenever it should be.
Yeah. Programme itself, obviously, as I say, there's a small programme team. There's myself, a project support manager, and the clinical experience of Sally within that. But there's no annual budget in that. We can, when we have specific things, we'll look for slippages in, but there's no actual funding against Palliative Care and Partnership.
Okay, and nearly to a man and woman, everybody that has come before us has said we need a clinical lead. Is that something that would supersede your role or complement the role of the PCAP?
I think it would complement it. I certainly would welcome a clinical lead. If we look at it from 4 countries, Scotland, England and Wales have it. Republic of Ireland have it. Even if we look locally, our cancer networks, our frailty networks, etc., have a clinical lead. And I think if we are committed to transforming palliative care, then I would welcome that leadership, that advice and that guidance of that clinical lead. But it comes at a cost. It needs resourced. Yeah. But I do think that it's one of the things that I would like. But obviously I'm here as a clinician. I walk a tight line sometimes. Diane and I maybe don't always agree because we're looking at things from a different lens. And I come from that clinical perspective, and Diane's coming then from policy perspective. And both are valid, both are required in the room. And I think Diane and I work very well together. And usually any of the things that we don't agree on, we eventually work out. We have a process of working through those. But it's about me respecting Diane's view and Diane then respecting my view.
I think certainly a clinical, I mean, the Palliative Care and Partnership, we do have the clinical engagement group, which was set up at a point in time, and that came from one of the RKIA recommendations for a managed clinical network at that time. And there was loud voices at that time around the multidisciplinary approach of palliative care. So that's where the clinical engagement group that Sally currently chairs sits within our programme, and it is really useful in getting some of that guidance and things and those work streams progressed. But again, I mean, I think we're in a different position now. I would welcome any support into, you can see how big the agenda is in this space, so any support in this space I think would be welcomed by all of us.
Again, everybody that has given evidence to date has talked about the public awareness issue and the lack of conversations and the lack of knowledge and information in the general public. So, I mean, how can the PHA, for example, improve with the education of the general public moving forward?
Certainly, we do work, obviously, and provide funding. So we're very, very conscious of the need to normalise those conversations around dying, death and bereavement. And we support, we secured 3 years funding for the Compassionate Communities Northern Ireland. And you've heard from Sharon Williams and Fiona Gilmore and Crew's Bereavement just about the work that they're progressing around our death positive libraries and making sure there's literacy out there for the public. We're also they're working into schools and trying to work with council areas as well. But we're very aware that project is small. Alongside that, then, we're providing funding to the All Ireland Institute as well, then, to support that public messaging. And we do quite a bit of that during Dying Matters Week and Palliative Care Week. Could we be doing more? We absolutely could. But even our Compassionate Communities position paper that was launched by the All Ireland Institute, we have funded that and supported that. I've been present for those death positive library launches as well. And you know, we're looking creatively at how we can progress, because from my perspective, I'm looking at things from a population lens. So how do you reach the members of the public that maybe cannot read or don't want to read? And social media is a vehicle for that. And you will see, if you're linked into Facebook, Sharon Williams, you know, was regularly tweeting out or putting messages out through Facebook. I think the Northern Trust is an example of really good practice in relation to that public health approach, and they've really embedded it within their trust. And Fiona Gilmore works very closely along with Sharon Williams, and I know the plan is, and Diane's working very closely with Sharon to look at how do we spread the reach that Sharon has out around the rest of Northern Ireland and beyond. We're part of a Compassionate Communities community of practice with Southern Ireland, very conscious that our border areas, you know, we need to be given the same message right across the island of Ireland, because I think that's what's happened. There's a lot of mixed messaging out there. But I think we all have a role to play, and sometimes people look at health, but the Compassionate Communities is more than just health. It's right across all the programmes of care. And I think unless we embed it into our schools and councils and into our community groups, the other part about it is it's something that we don't lead on. We empower our community, and in order to do that, we need to know where the weaknesses are and where the strengths are in particular communities, and what we need to do to support those communities. And certainly, you know, some of the intelligence that's there within the Public Health Agency will support us to do that going forward.
Danny?
Thank you, Chair. Thank you very much for that. It reinforces a lot of the stuff we've heard before, but also fills in some of the gaps. I was going to ask the question the Chair asked about the clinical lead as well, so great minds. Could I ask just about your engagement group, the clinical engagement group? Has that delivered anything in particular? Have we seen any practical changes to palliative care because of the clinical engagement group?
Well, I chaired the clinical engagement group. I'm only in post over the past 2 years, and one of the key pieces of work that we've led on, or that I've led on over the past 2 years, would you believe, is the syringe pump guidance document for adults. And alongside that, then I've led on paediatrics as well. Whilst I'm not paediatric trained, we were approached by paediatrics, could they join our group, and we've brought them in as well. Now, that document, it grew legs as we worked through it, and we have a document now that no matter where you're at in Northern Ireland, and you're a clinician, you can lift the same document. You've got the same guidance around prescribing, administration, education and training has been standardised within it, and audit and governance has been standardised within it as well. And then, you know, the very practical issues then, how does people, because there's no point having a glossy document if it's not usable. So we have 10 appendices, and that was, you know, I assigned 12 months to do the first part of that project, but we ended up then, we've got a patient information, patient and care information leaflet, so that no matter where you're at in Northern Ireland, those patients and carers will receive the same information. And that works because we're across multiple agencies and across trust boundaries. We've got a quick reference guide now, so that if you're under pressure on a ward or in a patient's home, you can lift that quick reference guide and quickly look down through it and get real clear guidance about how to use that syringe pump. We've got a standard operating process within it, because there was an issue around de-prescribing, discontinuing prescription charts in the patient's own home. So we've put a standard operating procedure in there that will allow the nurse to have a conversation on the telephone and to stop that prescription. We've got a competency document within it, so that no matter where in Northern Ireland, whether you work in hospice, whether you work in hospital, that you are reaching the same level of competency in relation to using a syringe pump. So that's one of the things that we've led on. There's other things like there was an issue basically with prescribing. Our hospice colleagues are unable to access cipher codes and prescription pads in community. And certainly it was brought to our attention, especially in our rural areas, where they were struggling with the GP. The family, maybe person would see the patient in their own home. They didn't actually have the prescription pad there, and there wasn't a process for them to actually use their prescribing qualification. And that patient obviously could be an OMA, and the doctor who's on at the time could be an Altnagalvin. And then there's travel distance, as you can imagine, between decision to change that prescription and that prescription being written. And what we done, we took a look at that. We've worked along with the Foyle Hospice, our primary care partners. Andrea Linton from New Models of Prescribing and SPPG has worked along with myself. And we've chaired a steering group over the last year, where we've put a process in place, and it wasn't easy, because once you start crossing boundaries between trusts and different care settings, there was, you know, that communication process, because one of the things you don't want to do is where you have somebody prescribing a drug and there's a potential for duplication with a GP prescribing that drug as well, or not knowing that that drug has actually been prescribed. So there was a bit of to and fro to get the communication processes aligned there. We managed that. And we had a celebration event in the Foyle Hospice last week, where we presented the findings, and it has shown us that we've significantly reduced the time between decision to prescribe and the patient receiving the medication in their own home. Small scale study, but we're looking now throughout, you know, our next steps, our next meeting will be, how do we scale and spread that across Northern Ireland? to have a bigger impact. So those are the type of projects that I have led on since I've come into post. There's other things, but I'll not go into the detail of them now.
Those are fantastic, and it's great to hear that, because those regional variations are things that we hear again and again and again, and the fact that they're being picked up and addressed, and that's being ironed out effectively.
I think
it's hugely beneficial.
I cannot underestimate the amount of time and energy it takes, to get everybody to come to agreement, and I think whenever others have presented, they've talked about a regional approach and a local approach. And these sort of things is sort of the regional approach is the syringe pump guidance, but the local approach, because we're going to move hospice by hospice now to make that a reality and scale and spread it. So that's where you need, both your regional approach and your local approach to actually get over some of these things. But I have a mindset. I look at a problem, but I look at the solution, and if you remain solution focused, I do believe there's a way of getting around even the most difficult things. I've worked in palliative care as a clinician for 20 years, so I know most of the teams. I know most of the those intricacies that leave it difficult for cross-boundary working, and I can usually find ways around it.
Absolutely, and I commend you on your work. That really is fantastic, and your celebration is well deserved. Reducing the time for a patient to receiving a drug is an absolutely fantastic thing to do. One last question, if the chair permits. Clinical engagement group. You'd said there was a drop in mandatory training in palliative care. I think it was yourself, Diane. Why?
I think, as I put in the opening remarks, it is, and this is anecdotal, but it is most likely to do with pressures on the system, people being released for training, priorities. We've seen it particularly after COVID, the NICEL results and Sally and I have just met with NHS benchmarking the NICEL results for Northern Ireland for this year due out in October, so we've had an initial meeting about what that looks like, and it seems to have, we don't have the detail, but dropped again. But I think it is just pressures with the system and other priorities, going on to training. But, we would say the priority we have around education and learning, and I should say in this space, I've been in this space in palliative care for 12 years. We've run a lot of task and finish groups, and as Sally says, none of these things, because you have so many people around the table that need to be involved in these, so none of these things are easy, but the education and learning piece is probably the most collaborative piece we have ever run, and we've brought into that the home care sector, who are crying out, who are seeing a lot of these patients day and daily in home, looking after them in their own homes. They want to have more learning in this. We have our universities engaged, we have our clinical education. I have primary care practice-based learning managers emailing me to say we want to be involved in this space. Our problem actually in this is facilitating all of that. So, it's certainly a priority for us to see what we can do in that space.
And I suppose just to add from a clinical perspective, I really do think that we need to move in Northern Ireland to make it mandatory training. Basic life support is mandatory, and yet, as a clinician, you might never see or need to use your CPR training, but it'll be seldom that you will work in clinical practice and not be involved in some shape or fashion with somebody that is dying. So I think one of the things that we'll be hoping that will happen maybe as an outcome of the work that Diane's doing, and it is a huge piece of work, that mandatory training for all staff, because I think that's our best move to make sure that everybody gets that training on a regular basis.
Thank you very much.
Amanda?
Thank you, and I apologise that I had to step out for a minute, but well, first of all, just in relation to that piece of work, so if we can get some feedback in relation to what exactly is going to be included in that whenever we have that, would be really, really good. Just on DNRs, it's something that has come up in nearly every presentation that we've had by every level of clinicians, the ambulance service, the community providers as in GPs and so on, hospice. So obviously I'm quite sure you're well aware of the challenges. So somebody is in hospital setting, signage in, or that's that put in place to get into an ambulance to go home. It has to be put in place again. The get home, it has to be put in place again. I mean, that is so traumatic for the individual, for the families. I mean, to me, it seems like something that could be fixed, and I just want to understand, do you think it could be? And I'm looking at you, Sally, because you are solution focused, and I want you to get this across the line for us.
No, I absolutely do think it is fixable. But to say, I think we need to realise that the health service is a complex environment, and no matter what we do, it we'll always have occasions when we just do not get it right. But I do think, and we are moving with the advanced care plan and policy, and the respect form and process within that will hopefully address some of those issues. Now, I know we'd love to be moving quicker with that, but there's real complexity with making a change as big as that right across all care settings. It's going to be a societal shift. So, there's going to have to be some sort of public messaging done around that. We'll also have to create an environment where our workforce are skilled and ready in all care settings to have those conversations with the patients and their families. And some of those conversations are reasonably simple, but some of them are quite complex. And what we do not want to do is add further distress to our patients and relatives. We want to do it in a pragmatic way. We do not want a disjointed approach to that. And I suppose that has been some of the reason why it has probably got delayed a little bit. Encompass was a big system to put into our health service over the past year. And would it be right to actually launch into, changing our DNA forms over to the respect form? Maybe not the safest time to do it. And I think, I come from a local organisation, worked in the Northern Trust, worked in the Belfast Trust before, and when you look at it from a trust level, you think, goodness, this is easy. Now that I'm looking at it from a lens, from a population, I do not want to put anybody through any stress, but I am fully supportive of getting this moving if we can, and some of the work within the big discussion will allow us to test some of that, but also to work up some of the education and training as well. So it's a big piece of work, and it's probably going to take a bit of resource and time to make it a reality. But I am committed, certainly, and I think we're all committed. It's just about moving it forward.
It is, so the respect forum is part of the advanced care planning policy. That's our intention to do that. And we do now have a vehicle, through the winter preparedness work streams to start intensively working on that. So that is a plan. As Sally mentioned, there's complexities around it as well.
No, and I do understand that. So I think at least if we know that the work is happening, that we can potentially get it moved on. It might not be suitable for everybody, so I understand that this may have to be done in a phased approach. And I understand that, but I probably just want to say something moving on it. And I know that obviously in Encompass they did say that they're hoping at some point respect will be able to be incorporated into that, but not right now, and rightly so. But no, I really appreciate that. Thank you very much. Thank you.
Okay.
Thank you, Chair.
Sally, Michael, Dan, that's Sinead. Thank you very much.
Thank you very much.
Okay, members, moving on to item number 9, draft committee report on the LCM for the mental health bill. Can I refer members to the committee's draft report on the LCM? That's at page 3. Are members content to agree the report as drafted? Okay, thank you. Are members content that the report be published along with the appendices?
Agreed. Yeah.
Thank you. Item number 10, written briefing from the Department on respite services. Can I refer members to the written briefing at page 142? Just to let members know, we're going to have an oral briefing on this issue in October, but happy to take any comments if there are any at this point. None? Okay. Oh no, were you?
Yeah, just 1 second, sir. You're moving quite quickly. It's between 2 packs.
You have to be very nimble here when I'm on a roll.
I wonder just if we could ask for, because it is October, it's a bit of it's a bit massive length of time. families won't have school. Some send schools offer like a summer placement for a week every day, but families will be without assistance and help for the whole summer period, so it is important that we keep the pressure up. And I just wonder if we can go back for a bit more information, like there's Children with Disabilities Investment Oversight Board. It had its first meeting, but it doesn't really say much about it, who it is, like on it, so that we can actually also hear from them too. So
Okay.
it might be worthwhile if we could go back and ask them about that, and to be kept updated through correspondence. I don't know how that happens or what's the protocol over the summer with regards to Lindsay House, because it's been another delay. I don't know if the committee gets correspondence over the summer or not, but I think, I mean, if we were to wait to October, that's and also questions, we can't submit them after next week. We can write letters, but I don't know if it might be a bit stronger coming from the committee, just to keep on top of the issues at Lindsay House and further delays with that. I know that there was an emergency placement, but it's just trying to see.
Just to say, Chair, that we do continue to correspondence in over the summer.
Okay, that's good. Well then,
do a number of responses. Generally, what we do is we keep it all together. So we do, and then give it to members in one go. I would be broadly content to issue it to members a batch at the end of July, and then another batch at the end of August. Just to
keep us updated,
just for information.
Yes,
so it is.
That'd be helpful.
They will all then go into the first pack back in September if there's any formal actions to be taken.
Yeah.
But just if members want to be kept informed of what responses we receive in, we'd be happy to send one batch out at the end of July and one batch at the end of August.
Just this issue, I'd just like to keep the heat on, because I know we're not coming up until October and there's a few months, but this is the period whenever families could be in most crisis because they do not get a break.
I mean, if we are getting correspondence sent to us for information, then I suppose even individually we can use that information to contact whoever we need to as well. Danny?
Yeah, thank you, Chair. Just following on from what Nuala was saying, a lot of the figures that we have been given are going the wrong way still, despite a lot of the investment that the Minister had announced in, I think it was October, November. We're not seeing any increase. We have an increase on children on the waiting list for respite care. We have more children on the edge of care, which is families in crisis. So things are going the wrong way despite this investment that the Minister had announced so publicly. So it is very, very concerning, and certainly I know my office has been dealing with families in the local areas, as I'm sure everybody else has, just about the impact of this on family lives. It really, really is horrendous what people are having to deal with. So yeah, I would agree with Nuala absolutely that we keep the pressure up on this.
Yep. Okay, everybody's happy with that. Okay, so item number 11, again, it's a written briefing from the Department on the review of emergency general surgery at the South West Acute Hospital. It's at page 13, of our table papers. Any commentary on that? No? Okay, Alan?
I know my reading of the word should when it comes to being admitted directly to a surgical ward. The Trust still are not meeting what I would believe should being 100% target. They're sitting there at 79%. I know that they're patting themselves on the back that they've increased from 26% to 79, and whilst that is welcome, but they have still some distance to travel.
Could we write to them just on the back of that and just say that the written briefing was given to committee and we're still very concerned about that issue? Happy enough with that?
Could we clarify, percentages can hide a whole lot of things. Could we actually pin down figures?
Well, that's
an exact figure?
Just ascertain how many individuals that percentage figure represents.
Okay. Also, are we still scheduled to go to the South West Acute Hospital for a meeting? It was on the forward work programme at one stage for September-ish.
It is there for somewhere in the autumn time. So it is, yeah.
Okay, perfect.
Okay, moving on. Written briefing on the Adult Protection Bill. I'm just going to hand over to the clerk just to run through this item.
Thank you, Very much, Chair. You'll see at page 179 of your pack onwards, there's a bit of a memo there in relation to consideration of the Adult Protection Bill. The second stage debate on this is Monday, so that'll be members' chance to debate the principles of the bill and then decide whether it passes on to committee stage. If it does pass, committee stage will start the next day, which does put us in a tight situation based on we have one meeting left until the summer. So I've made a couple of suggestions in relation to trying to progress this as quickly as possible. You will see there at page 180 is a draft timetable for consideration of the bill. This would allow the call for evidence to go out at the start of July and run until the end of September. You'll be aware if we put things out over summer, we don't always get the best responses, so that's why there's a wee bit extra putting it towards the end of September just to allow that additional time. You'll also see there we would expect to maybe start oral evidence sessions in November and December. Then into January we're looking at committee deliberations, so that's a chance to look at amendments, consider not just committee amendments but departmental amendments as well, and then going through the formal clause by clause process in February. So you'll see there that I've suggested extension through to the end of March. That just gives a wee bit of leeway at the end, so if we come up with a particular issue and we want to spend a bit more time on it, that is it's a limit, it's not a target. So the idea would be is if we decided that based on the evidence we don't need as many sessions, or there's less amendments, we don't need the deliberations, we'll look to report as soon as we can. So again, fortunately or unfortunately, this is based on experience in previous mandates. I'm not sure whether that's fortunate or unfortunate. Those members that were on the committee last time will still probably have the wounds from that period, but
so March of which year are we hoping to?
So really it's just again, this is looking at a bill of this size, sensitive issues, complexity, without really knowing what might come in the call for evidence. So again, this is best suggested, and again it's down to members to agree with that, and then if members did agree around that date, then I would draft a motion to extend that we could look at next week, which would then be debated in September time. Also, it'd be useful if we get agreed to call for evidence to go out next week, obviously subject to passing second stage. And then the final thing, you'll see there's a suggested stakeholder list, just outlining the organisations we would directly invite to give a written submission. That is not a definitive list, so if members had other organisations, I would ask that you say to me, or you can email me a list and we'll get them added to it. There's absolutely no problem with that. This is largely from a list of organisations that engaged with the department during the process of putting the bill together, so we've sort of built on that. And then there is a memorandum there, it's called Delegated Powers Memorandum. So that outlines all the secondary and delegated legislation that comes out of the primary bill. So again, it's to get formal agreement to send that to the examiner of statutory rules to consider. So I'm happy if members have any queries or questions on it.
Nola?
Thank you very much. It's helpful. Given just this is my first term, I'm looking forward to getting to this stage now of actually having legislation before us. And I just wanted to ask regarding the written stakeholders and then written evidence and then oral evidence. Just on the list, I would be keen. I mean, it came from the Dunmurry Manor Care Home, and then we had the Muckamore as well, and just keen to get families, because there are a family representative body and they are largely just the families themselves who have gotten together to form a body, and people and they have regular meetings and people who speak for them and stuff, and it would be really important to hear from them. So I don't know if they need necessarily, and it would probably overburden them, I imagine, for written evidence, and so it's just ensuring that they could be in the oral evidence at some point. Not sure how that's done, but
generally the way we would run it is we would put out the call for written evidence. Once all that evidence comes in, we have a role in summarising that for members and providing a summary of the responses, and then we would make recommendations on which organisations to hear from. Alongside that, I know the committee generally wants to hear people with lived experience. So we will look at, alongside that formal evidence, whether it's informal or whatever way that it is, we'll look to bring in that lived experience. And if there are representative groups, I know in the past we worked with PCC, if there are other representative groups, we'd be happy to engage with them to see how we could get them to feed into the evidence. Because on some occasions a formal evidence setting isn't always appropriate. Sometimes it is, but that's where we would try and have a discussion and see what's the best way to bring that lived experience to members. But that will run alongside the formal evidence sessions in November and December, along to be a bit of a two-track approach to it.
Okay, members, so can I thank Keith and his team for doing all of that? That's very useful and very helpful. I'm surprised, I was a bit shocked when I heard this was your first mandate even, and first piece of legislation. I thought you were about in the previous mandate.
I was, but not as an MLA.
There you go. There you go. So, I mean, members, are we happy enough to agree that as outlined by the committee clerk?
Yes.
Okay, thank you. Thanks very much. That is very useful, and we can look forward to beginning work on legislation, an important bill. Okay, item number 13, draft human medicines, authorisation by pharmacists and supervision by pharmacy technician, order 2025. Page 199, there is a written briefing notifying that the committee that the order will be laid in Westminster. So there's no formal process for this committee in relation to this order. It's for information only. So happy enough with that? Okay. Correspondence, item number 14. Can I refer members to the response from the Minister at page 24 in the table papers on bereavement services in schools? Can I ask if members are content to note as part of its evidence gathering for the committee's inquiry?
Yeah.
Okay, can I also refer members to a response from the Minister at page 32 of table papers to a letter from myself conveying the committee's concerns following a meeting with families on the 5th of June who were involved in the complaints process and the serious adverse incident reporting process of trust. So the committee had asked that he meet with the families as a matter of urgency. And he's basically come back and said he didn't think it was appropriate during the consultation process. So I'm just not sure I was happy with that response, to be honest with you. I don't see any reason why during a consultation process you couldn't meet with those most impacted and likely to be able to give you some aspects of concern. That would, I mean, that's consultation in my view. So I was going to suggest we go back to the Minister and ask him to reconsider.
I agree.
Is everybody happy with that? Or sorry, at the very least, if it is inappropriate, and I don't think it is, that as soon as the consultation process is over, that he agrees to meet. So he's not just putting it off, that at some point that he meets either during the process or very quickly after.
And give us grounds for the inappropriateness of it. Just not it's inappropriate. You understand why. There may be limits to where the conversation can go, and I understand that. But
I just think if there's a consultation out where you're trying to find out everybody's opinion, then you should be speaking to people who have a very strong opinion based on their own lived experience. But anyway, so if everybody's happy enough, we'll do that. Can I refer members then to correspondence from an individual, page 35 on post-19 provision for adults with complex needs. Do members have any commentary on that? Linda?
No, just to say, obviously, you hosted an event in the Long Gallery during the week, and it was a really, really good event, and organised by parents and, you know, done of their own volition. And it isn't easy to organise those events. I'm going to get into what happened because that's not important. But what I was going to say, I think maybe we might want to consider a conversation around this, because the Economy Minister has done what she can do in terms of post-19 provision for those young people that will fall under that department. But the other departments now need to come up to the mark, you know, and I've said this repeatedly. Why are we not identifying these children and young people at the very earliest stage in the health system, and bringing a plan right through their health and education and, you know, potentially economy and communities, all of those, but a plan for them for their life that can be added to as they go through their life. But that starts at health.
I mean, at last week's meeting we agreed to write the Minister on that very issue, so we have wrote to him, but we haven't got a response back. So whenever the response comes back, we will do that. And there, I mean, there's quite a lobby in there just in relation to Caleb's cause, so I think the agreed format is the Department for the Economy are going to respond to all of those in relation to that. Okay, and then just also at the very beginning, because we had a number of correspondence last week in relation to the RVH, cardiac unit and level 5 intervention in terms of reference. So there was a number of correspondence in relation to that. As I say, myself and Danny met with Peter McBride. I mean, I'm certainly convinced that there's going to be a thorough piece of work there, and hopefully that will help to improve the situation. He said there's 22,000 members of staff within the Belfast Trust, and he's going to make it himself available to them all. I don't envisage 22,000 members coming forward, but that, you know, he's going to be open to, and it's going to be engaging with the trade unions and obviously senior management and clinicians, etc., etc. So, Colin?
Sure, will we be getting some feedback on that? Because post the session that we had here 2 weeks ago, I've literally been inundated with people contacting me about their gripes, and I think that we need to be making sure, just if there's regular correspondence, just to make sure that this is being dealt with, because this cannot be brushed under the carpet, and it can't be just we've got this little system going where somebody's going to go and check. I think we need to be keeping an eye on this as a scrutiny committee, and that we need to be assured that what's happening in the Belfast Trust with those cases, because I'm fairly confident there's more to come, and I'm sure that will be in the next week or two, but we just need to keep an eye on this, because I don't think this is a small issue.
No, I mean, it absolutely isn't, and I mean, certainly I have been contacted. I'm now referring people to Peter McBride as a point of contact. I mean, we did raise all of it. I mean, you'll have seen the terms of reference. In our conversation, we talked about the whistleblowing processes, etc., that are currently exist. So, I mean, I would expect plenty of recommendations coming out of his work in relation to this. So, I mean, I think if we can individually direct people, if they want to, they should be making themselves available to Peter and his team. And I mean, he has assured us he will come back to us once recess is over and give us an update. I mean, the report is for the Minister, but he will certainly come to the committee. Danny?
Sorry, just to follow up on that, I got the impression that Peter is going to make himself very accessible to all staff, and any staff with problems, like I absolutely would direct them, like the chair, towards that inquiry, and, you know, will have strong recommendations.
I mean, just as part of that correspondence list, there's also an individual who has sent us, so I'm going to suggest that the committee forward that letter to Peter McBride as well, if people are happy. Okay, any other issues within correspondence, Linda?
Just a very quick point. I was at an event just for a few minutes upstairs for young carers before the meeting here, and they have a number of asks. So if I forward that on maybe to Keith, and we can just look at what is relevant in terms of health, we may want to write to the Minister around their asks. It's just 3 key asks. One of them will not be definitely not be of health or communities, which I'm going to pass on, but I think we need to do all we can to support young carers.
And then just lastly from myself, there was correspondence to myself which went to the committee from Diabetes UK and who's the other one? Versus Arthritis, looking to brief the committee. So can I suggest that the staff sort of engage with them, whether it's formal or informal, after a recess, that we get a briefing from both those organisations? Happy enough for that. Okay, any other business? None. Everybody's getting ready to go. Date time, better get in there quickly before you're out the door. Date time, place of next meeting, Thursday 3rd of July, room 29, 2 p.m, and that will be our last meeting.
Committee Room 29, Sound.